scientific evidence currently available indicating a lack of benefit. And on June 15, the FDA actually revoked the emergency use authorization for these agents. So now the public at large doesn't have to think about the potential cardiac effects of hydroxychloroquine anymore. But unfortunately, the lupus community who remain on this agent, this question is still relevant. It is still pertinent, especially in light of the fact that we're hearing in more recent weeks that COVID-19 itself can be associated with significant heart disease. We're hearing about college athletes who are supposed to be the most healthy in the population being assessed as having myocarditis weeks after having recovered from COVID-19. So this concern about hydroxychloroquine and the heart period is compounded by the fact that we're in the middle of a second wave in most countries, and COVID-19 itself can also affect the heart. So in the next 25 minutes or so, I will review the role of hydroxychloroquine in lupus management. We have to talk about heart disease in lupus itself to understand how hydroxychloroquine may interact with that. We will look at the effect of hydroxychloroquine itself on the heart in lupus, and we have to review cardiac safety data on hydroxychloroquine in COVID-19 to determine why this question of problems with the heart arose. Then we will look at early registry data to see what is really happening to patients with lupus who acquire COVID-19. And you just heard quite a bit from Professor Curicchio about that. And then we will end by a quick glance at the guidelines, which we'll go through pretty quickly because you just saw some of them. It is important to first note that hydroxychloroquine is the cornerstone of lupus management. This timeline summarizes drug development in lupus. And what you will see is that it has taken over 50 years for another agent to be approved for the management of lupus, belutamab. In that gap of time, over 20 clinical trials have failed to produce an approved new therapeutic agent for this disease. Now, hydroxychloroquine is not only important because of the relatively limited drug options in lupus, it is important because of its multiple mechanisms of action, which have been elucidated over the past few decades. These mechanisms of action address the fact that lupus is a disease characterized by loss of self-tolerance. And for our patients online, as you know, that means the body no longer recognizes itself, leading to the production of autoantibodies. So the immune system is attacking its own tissues. There is also the production of immune complexes, and these cause organ dysfunction and tissue damage. Now, the main mechanism by which hydroxychloroquine modulates lupus is by suppressing toll-like receptors, especially in the plasmacytoid dendritic cells. So the toll-like receptors exist on the surface of endosomes, which are the intracellular sorting organelles that regulate the trafficking of proteins and lipids and, amongst the subcellular compartments. They sense nucleic acids, and they become activated, and this activation is necessary for the expression of interferon-regulated genes and for the production of tumor necrosis factor alpha. And these are key in the cell-mediated immune response. And this is what characterizes, and it's very important in the pathophysiology of lupus. Now, hydroxychloroquine prevents toll-like receptor activation by binding directly to the nucleic acids in the activation pathway. And in vitro studies show that blocking this pathway blunts the body's primary cell-mediated response. And in vivo studies show that the use of hydroxychloroquine is strongly correlated with a reduction in interferon alpha levels. Emphasized less now, but still relevant, is the alkalinization of lysosomes and other intracellular compartments. And this increase in pH causes a selective change in the way in which antigens are presented. Beyond the TLR signaling inhibition, experimental studies show that hydroxychloroquine may decrease the activation of T cells, the T cell response, and the concentration of pro-inflammatory cytokines, some listed here, but others include interleukin 17, interleukin 22. And all of these ultimately lead to the decreased production of autoantibodies. This diagram also shows the effect on coagulation. There is a distinct antithrombotic effect of hydroxychloroquine, which is independent of the antiphospholipid antibody status. It decreases platelet activation and decreases platelet aggregation in a dose-dependent manner, and can also decrease antiphospholipid antibodies, and through its effect on nitric oxide, can reduce endothelial proliferation. And all of these are very important and very relevant in the reduction of cardiovascular events like myocardial infarction. And when we look at other effects of lupus, of hydroxychloroquine and management of lupus, which are relevant to this talk, we also see that there is a reduction in lipid levels, 8% reduction in total cholesterol, 14% reduction in LDL, and an increase in HDL levels. The average blood glucose is also reduced in patients in a non-diabetic population of lupus patients. And ultimately, hydroxychloroquine reduces the oxidative stress that accounts for the cell and tissue damage that we see in lupus. And for our patients online, this slide is yours. Perhaps this is the most important slide of this talk for you. Because of all these multiple effects, hydroxychloroquine is recommended for all patients with lupus. Of course, if there are any contraindications that your individual assessment by your rheumatologist picks up, then you would be excluded. But this is a universal recommendation because of the myriad of wonderful benefits from taking this drug based on the mechanisms I just showed you. It lowers overall disease activity, reduces flare rates, disease and damage accrual. It's steroid sparing even in patients with very severe disease. Renal remission, so patients who have lupus nephritis, they maintain remission or increased remission occurs even when they're on mycophenolate mofetil. The addition of hydroxychloroquine increases the remission rates. There's a lower frequency of seizures and neuropsychiatric damage. Pregnant women, you never stop your hydroxychloroquine. There's a reduction of flares, and we know flares portend an adverse outcome for both mom and fetus. And there's a reduction in the risk of congenital heart block in babies born to mothers with anti-Ro antibodies. More recently, we're hearing about reduced breast cancer and non-melanoma skin cancer rates. And those patients who attain remission, staying on hydroxychloroquine maintains that remission. So even when you're in remission, you never stop hydroxychloroquine. And very importantly, there is improved survival. In fact, it is the only drug in lupus management that currently improves survival in patients with lupus to the order of at least 50% with a high level of evidence. And this is on the basis of the reduction in vascular and thrombotic events based on these effects I just discussed: anti-inflammatory, anti-thrombotic, anti-hyperlipidemic, and anti-hyperglycemic effects. So we have to look a little bit at heart disease in lupus to understand the relationship between hydroxychloroquine and the heart. Now, the risk of cardiovascular disease and heart failure is in fact increased in patients with lupus through multiple mechanisms. There is a higher burden of traditional risk factors through autoimmunity, that is the abnormal immune response that leads to cell death and damage, and the chronic inflammation that characterizes this disease. As this diagram shows, these contributing factors are intricately interwoven. Furthermore, the drugs that we use to treat lupus may be contributors to heart disease whilst also being of some benefit. Important to point out are some specific contributing factors. When we look at them, advanced age, male sex is important. This is lipidemia. In particular, I want to highlight total cholesterol, elevation and serum triglyceride levels that can increase up to twofold risk of cardiovascular disease. So we have accelerated atherosclerosis occurring, and with coronary artery disease rates as high as 48%, depending on the modality used to assess for the presence of coronary artery disease. And coronary artery disease increases the risk of myocardial infarction, some 2 to 10 fold in patients with lupus. It's also important to note that greater disease activity, longer duration of steroid use, and longer duration of lupus also increase the risk of accelerated atherosclerosis. Now, in addition to this, there is also the increased risk of conduction diseases in lupus, as well as myocarditis, so myocardial inflammation. In general, the immunomodulating therapy for lupus is thought to improve the cardiovascular risk profile through the reduction of disease activity. And we just went through some of the very specific ways in which hydroxychloroquine may contribute and may modify all of these risk factors and all these contributing factors, including the fact that it is also steroid sparing. Unfortunately, however, there is a question that hydroxychloroquine can also contribute to heart disease in lupus through conduction abnormalities and structural changes of the heart in particular. The toxicity associated with hydroxychloroquine may be acute, or it may occur with long-term use. Looking at acute toxicity, we see that this is particularly relevant in high-dose use or where there has been self-poisoning. And the mechanism by which this occurs largely has to do with the effect on sodium and calcium and potassium channels. The blockade of these channels leads to a membrane stabilizing effect and then prolongation of the QT interval, which can potentially initiate ventricular arrhythmias. In particular, we're concerned about torsade de pointes and the increased risk of sudden cardiac death that occurs with this. This is especially the area that is of special concern with the use of hydroxychloroquine generally and in patients with lupus. Other effects include peripheral vasodilation through alpha blockade and histamine release. Widening of QRS interval may lead to various blocks, AV blocks. And then the cumulative toxicity. So these are patients who are on hydroxychloroquine, long-term treatment, or where there's a high cumulative dose. The mechanism of action has to do with the dysfunction of lysosomal enzymes, leading to the impairment of clearance of intracellular products, such as phospholipids and glycogen. And this leads to a kind of acquired lysosomal storage disorder that leads to a drug-induced cardiomyopathy. It's characterized by concentric hypertrophy, conduction abnormalities consequentially associated with adverse clinical outcomes and mortality. So what is the available data? This is the first systematic review related to cardiac disorders attributed to the treatment with hydroxychloroquine and chloroquine. And what it showed is that in the last decade, they found an increase in the number of reports of cardiac disorders. Importantly, looking at papers published, 86 articles picked up 127 patients. Chloroquine was more commonly used than hydroxychloroquine, 59 versus 40%. The treatment duration, fairly long, a median of 7 years. Patients were on these agents up to 35 years in this study. There was a relatively high cumulative dose, a median cumulative dose of over 1,200 for hydroxychloroquine. What they found was conduction disorders were the main side effects reported, 85%, be it bundle or AV blocks. Second in line was heart failure. So we're looking at 85% of conduction abnormalities, 27% in terms of heart failure. Other findings include ventricular hypertrophy, valvular dysfunction. What was interesting is that when these agents were withdrawn upon the identification of cardiac toxicity, progression occurred in quite a few of the patients, leading to irreversible damage. 12.9% of patients required pacemaker or heart transplant or some other intervention, and death actually occurred. So the conclusion from this systematic review is that chloroquine and hydroxychloroquine related cardiac disorder is rare, but when it occurs, it may be a severe adverse event. Now, this study looked at the rates of cardiovascular adverse events reported by the FDA Adverse Events Reporting System. So this is a global database for post-marketing safety reports. And so with all the noise in the COVID-19 era, these researchers wanted to know what exactly is the real world data in the pre-COVID period. So in this database, which had over 6 million reports, over 4,000, almost 5,000 reports of hydroxychloroquine and chloroquine-related adverse events were noted. 14% of these were cardiovascular adverse events, and compared with the full database, hydroxychloroquine was associated with a high reporting rate of major cardiovascular adverse events, cardiomyopathy, 1.8%, QT prolongation, which is a major concern, 0.9%, cardiac arrhythmias, 2.4%, heart failure, 2.8%, and the mortality attributed to these adverse events was 8%. There was no difference with regards to age and sex, which can affect, for instance, QT prolongation. And the cardiovascular events were more often in patients with lupus and Sjogren's syndrome. But we know that these are the populations that use these agents most frequently. So what were the associations between QT prolongation and ventricular arrhythmias? Concurrent use of other agents, which may indicate underlying cardiovascular disease as well, and importantly, to note overdosing. And so the conclusion here is that in a real world setting, this is in the pre-COVID-19 era, hydroxychloroquine and chloroquine treatment is associated with higher reporting rates of cardiomyopathy, QT prolongation, cardiac arrhythmias, and heart failure. But as we can see, these rates are pretty low. So let's talk about hydroxychloroquine and its effect on the heart in lupus. We aim to study whether cumulative antimalarial dosing was associated with ECG abnormalities in patients with lupus. So the Toronto lupus cohort is a prospectively run cohort in which comprehensive data is gathered. And we looked at the resting ECGs done on consecutive clinic patients between 2012 and 2017, 473 patients, and this is the largest report at the time of the publication of our study, looking at specifically ECG abnormalities, whether they be structural or conduction abnormalities in the context of antimalarial use. So we looked at ventricular hypertrophy and atrial enlargement for structural abnormalities, the conduction abnormalities, of course, important prolonged QT intervals, and other various AV blocks, bundle branch blocks, other arrhythmias like atrial fibrillation. The data collected from our patients looked at potential confounding factors, age, sex, and other demographics, their disease activity, so their SLEDAI within 2 years, importantly, the presence of coronary artery disease or intervention thereof, including the need for stenting previously or CABG, and the history of pulmonary hypertension. Any possible confounder was addressed in these patients. So we aim to look at the associations between cumulative antimalarial dosing and the ECG abnormalities using a logistic regression analysis and a nested case control study. So for every abnormal ECG, we had 3 controls assessed. So the SLE duration at ECG, 19.7 years. The median cumulative dose we found was 1,207 grams at the timing of the ECG. We found that conduction abnormalities were more common than structural abnormalities. 16% versus 13% actually had both. And the cumulative dose, though it was shown to be significant in the univariate analysis, was not statistically significantly associated with structural abnormalities in the multivariate analysis. What we did find is that cumulative antimalarial dosing was protective for conduction ECG abnormalities. And the nested case control study actually confirmed this finding, that the cumulative antimalarial dose was protective against conduction ECG abnormalities. And the risk factor that we identified for both structural and conduction ECG abnormalities was the duration of lupus. And so we concluded that a cumulative antimalarial dose above the median of 1,207 grams may have some association with structural ECG abnormalities, but certainly this cumulative dose decreased the odds of ECG conduction abnormalities. In relation to our study findings, a similar prevalence of conduction abnormalities, 17%, were found in a French cohort of 112 patients after a 10-year follow-up. And we also noted that we had a lower prevalence of QT prolongation, 0.7% versus 6.5% in another Canadian cohort looking at 150 patients. And interestingly, they also noted an association with between QT prolongation and the presence of anti-Ro antibodies. A very interesting finding, which is also very reassuring, from another French cohort looking at 85 patients, was that the prevalence of conduction abnormalities in lupus is similar to the general population. So here we are, it's 2020. Why are we asking if hydroxychloroquine is safe with all of what we've known and for how long we've been using these agents? It is because of the COVID-19 pandemic and the repurposing of antimalarials as potential therapies. Though we're focusing on hydroxychloroquine, as I go through the effect of hydroxychloroquine on the heart in COVID-19, I have to mention azithromycin. So this retrospective cohort of hospitalized prolongation in hospitalized patients with COVID-19 treated with a combination of hydroxychloroquine and azithromycin. Patients received a loading dose of 800 milligrams and then 200 milligrams twice daily for 4 days. The use of this combination was associated with a significant QT prolongation, an average of 30 milliseconds, and 21% had a QTc greater than 500 milliseconds. We know this increases the risk of torsades de pointes some 2 to 3-fold. The follow-up was brief, 5 days, and during this time, no primary high-grade ventricular arrhythmias were noted. The change in QTc, importantly, was not associated with death. And the independent predictors for QTc prolongation were older age, the presence of congestive cardiac failure, higher creatinine levels indicating baseline renal impairment, and evidence of cardiac inflammation with elevated troponins, and persons with lower BMIs. And so the conclusion from this study is that despite the significant and progressive QT prolongation with hydroxychloroquine and azithromycin, no adverse arrhythmias were observed. And it's interesting, it's very important to highlight that azithromycin has been known from 2012 to definitely increase the risk of adverse cardiac outcomes through its effect on the QT prolongation. This retrospective study was from Michigan's largest health system. Now, looking at an Italian analysis published about a month ago, it's the largest assessment of the arrhythmic safety of hydroxychloroquine in a real-life cohort of patients treated in all clinical settings for COVID-19. The cohort of patients that were treated with hydroxychloroquine alone or in combination with other QT prolonging drugs, for example, opinavir or ritonavir, in addition to azithromycin. 58% had a loading dose on day 1 of 800 milligrams, and they were continued on 400 milligrams per day. The modest QTc interval prolongation was noted, a median of 13 milliseconds. The follow-up was 16 days with no arrhythmia-related deaths reported. Low major ventricular arrhythmia rate was noted of 1.1%, and these were written off as critically ill patients and not found to be attributed to hydroxychloroquine therapy. Importantly, the determinants of the QT prolongation noted were baseline QT length and the upper limits of normal and the presence of fever at admission. And so they concluded that hydroxychloroquine was not associated with any significant arrhythmia related to its administration in COVID-19, certainly for short duration of use. So what about COVID-19 and the heart itself? We just heard quite a bit about that. This diagram shows the bidirectional interaction between the cardiovascular diseases and COVID-19. Firstly, cardiovascular comorbidities increase the susceptibility, as we just heard, and increase the severity of COVID-19. Although the main presentation is of viral pneumonia and the consequences of that, the systemic inflammation that occurs with COVID-19 contributes to a higher incidence of acute cardiac injury, myocarditis, and acute coronary syndromes in patients, and very importantly, arrhythmias with QT prolongation, higher incidence of ventricular fibrillation and atrial fibrillation, and there's also thromboembolism. Now, amongst these cardiovascular manifestations, myocardial injury has been independently associated with a high mortality amongst patients with COVID-19. And of course, we just heard about hydroxychloroquine and its effect on the heart. So what is actually happening with patients with lupus who develop COVID-19? We just heard that there isn't a greater risk in terms of acquiring the disease and in terms of severe adverse outcomes, which is very reassuring. So the COVID-19 Global Rheumatology Alliance was established to collect, analyze, and disseminate information about COVID-19 and rheumatology to patients, physicians, and other relevant groups to improve the care of patients with rheumatic diseases. Now, what this database has shown is that in patients with lupus, the frequency of hospitalization with COVID-19 did not differ between antimalarial users versus non-users. 55% versus 57%. So being on an antimalarial did not increase the risk of severity of COVID-19. Neither, unfortunately, was it protective. So in patients with lupus, the escalation to maximal level of care, whether it be non-invasive or invasive ventilation or extracorporeal membrane oxygenation, ECMO, occurred irrespective of hydroxychloroquine use. And so as you just heard, the recommendations, which are fluid and changing, maintain that hydroxychloroquine should be continued as per the pre-COVID-19 recommendations, should be initiated at the full dose recommendation. Pregnant women should continue it. And we know that we just heard the EULAR recommendations indicate that, that patients with rheumatic and musculoskeletal diseases, they lump lupus into that category. They should continue their treatment unchanged. And so in summary, we've heard that hydroxychloroquine is essential in the management of lupus because of its myriad of benefits and improved survival. We've seen that cardiac safety data on hydroxychloroquine prior to and during the COVID-19 pandemic highlights the adverse effects of high doses. The prevalence of hydroxychloroquine-related toxicity in lupus is low and similar to the general population, which should be reassuring. Hydroxychloroquine does not increase the risk of hospitalization and complications related to COVID-19. And the current guidelines maintain that we continue the use of hydroxychloroquine as per the pre-COVID-19 era. And so I want to conclude with this slide from Zahid Touma, who was our supervisor on the study and recently did this editorial for the Journal of the Canadian Rheumatology Association. Rheumatologists have used hydroxychloroquine for decades without major side effects. We weigh the risks and the benefits. Certainly, each patient is considered individually when prescribing any agent, and I hope I have convincingly shown you that it is important to maintain hydroxychloroquine in 2020 because the benefits certainly do outweigh the risks. And especially we see that in cardiovascular outcomes. Thank you so much for your attention.
Thank you so much, Dr. McGee, for a very informative talk. So now we are officially opening the Q&A segment. I have a few questions here. The first one is for Professor Curricchio. Okay. So Professor Curricchio, you mentioned the role of the interferon-1 in the pathogenesis of COVID-19. Is there any role of anifrolumab in the treatment? Is it something that we're looking at?
Can you unmute me? Oh, okay. Yeah. So yes, well, that's an excellent question. We are looking forward to for a treatment that would stop this hyperinflammatory response, hence the damage. We've been using it significantly, and we are about to peer review the publication, but it's available on medRxiv. But there are several reports of the use of anakinra in COVID-19 when there is an inflammatory overwhelming response. And it seems to help, meaning that it does decrease the need for intubation and also decreases mortality. But none of those studies are actually in a format of double blind as a proper clinical trial. There is one ongoing in Italy and North America, although has not recruited yet fully. And it involves anakinra and emapalumab as well versus standard of care. So yes, the anakinra is one that everybody looks at because of its role in macrophage activation syndrome and its success in treating macrophage activation syndrome, as well as blocking interleukin-1 beta with canakinumab, for which the double-blind placebo trial has completed enrollment with close to 500 individuals worldwide on a one-to-one placebo versus interventional product, and we'll know if it works or not, blocking that pathway.
Okay, thank you. Dr. Hercule, you mentioned that the antiphospholipid antibodies in COVID-19 are transient. Now, should we be looking at repeating the levels of antiphospholipid antibodies post-COVID, or post the treatment period to determine the length of anticoagulation?
So that's a great question. So I'm sorry if I misspoke or I was misunderstood. I do not know if they are transient.
Okay.
What I do know is that they are transient in those individuals who do not have antiphospholipid antibodies, but they are positive in the context of blood clot, a DVT or a PE. Now, many of those patients will end up having a transient response, except for the very small portion in which actually they are permanent, and so that's helpful for the diagnosis of the syndrome. We need that data. We need the data in which those individuals will be retested, and I don't know what it will be. I'd expect though to be possibly transient, but if it's not, then those patients have bought themselves anticoagulation for life, though. For what because they would have the syndrome at that point. But for what concerns the anticoagulation, that's a very important question, because so the standard of care right now is to properly anticoagulate based on the procoagulable state, so the D dimers, for example, level. Of course, in the presence of a clot fully, but in the presence of high elevated D dimers, there would be an increased level of anticoagulation, aggressive level of anticoagulation. There are emerging data showing that the long-term risk of blood clotting for patients who did have hypercoagulable state during the COVID-19 is actually not there. So it actually weans off over time. And so anticoagulation, the length of anticoagulation after COVID-19 has resolved, it's quite short. But those data are still coming out. During the period of infection in the hospitalization, there is a clear risk. After that is much less.
Okay, thank you so much. You also discussed COVID-19 and immediate auto immunity. Now, what about long-term, do you think? The risk factor for COVID-19?
So there is a risk. So there are clinical trials ongoing, and in part sponsored by the NIH, to actually answer that question. So how long do we need to anticoagulate an individual that had an event, had a DVT or a PE during the COVID-19? That would go along with the rest of the recommendations that are already in place for an individual who had an acute event provoked in this particular case by the infection. So it depends on the severity, 3 to 6 months, but that is for persons who did have an event. But most patients actually, they just have elevated D dimers, significantly elevated D dimers. And the question is, are those also a risk after COVID-19 results, and those patients are looking at prospectively to see how fast that D-dimer resolves, and based on that recommend anticoagulation. There isn't a very strict recommendation for those who did not have an event.
Right, but outside of pro-coagulable events, I'm talking about the risk for development of conditions such as systemic lupus or vasculitis post-COVID-19 because of the risk it infers.
Of anticoagulation?
No, of COVID-19.
So the risk of COVID-19 in patients who?
No, the risk, sure, the risk of the development of autoimmune conditions in the long term.
I see.
In the long term.
Yes. So, well, we need data for that. That's the question that we all want to answer. If you have these induced autoimmunity in patients with COVID-19, is that durable? Is that actually something that will then confer higher risk? That is the question that we're all trying to answer that question. Okay. Yes, my expectation, if you want to know my expectation, I would expect the same as for the other viral infections that induce an autoimmune condition at the moment and then is transient. I would expect is transient.
Okay, thank you so much.
Sorry for the...
That's okay.
A good question.
Okay, so now a few questions for Dr. McGee. So Dr. McGee, just want to clarify whether there is or there is not clinical benefit in using antimalarials as COVID-19 prophylaxis. Someone is asking.
Yes, so definitely the data coming out of the registries indicate that there is no benefit. Patients who are on antimalarials, and so all patients should be on antimalarials, all patients with lupus, but unfortunately some patients don't take it or can't take it for other reasons, previous toxicity, retinal toxicity, and so on. What the data has shown so far is that patients who are on antimalarials versus those who are not on antimalarials, the rates of hospitalization are the same, which is one of the markers used to indicate the severity of COVID-19. There doesn't appear to be a protective benefit at all in lupus. And I should also add that in the past recent weeks, the patch trial was published, which shows that there is no benefit in taking antimalarials short term in the normal population. So this was a group of physicians who were taking 600 milligrams of hydroxychloroquine daily over a 2-month period, and the rates of development of confirmed COVID-19 infections were equal. So in the general population, no benefit in terms of prevention of COVID-19, and in the lupus population as well, there does not seem to be any protective benefit for taking hydroxychloroquine.
Okay, thank you, Dr. McGee. Another question, what is the HCQ, the hydroxychloroquine dose range considered to be high, and would that confer increased adverse effects?
So definitely higher doses of hydroxychloroquine with regards to body weight have been associated with greater cardiac toxicity, higher cumulative dose and longer duration of use of antimalarials. And this is of the order of greater than 6.5 milligrams per kilogram. Now, for those who may know, hydroxychloroquine was dosed at 6.5 milligrams per kilogram ideal body weight previously, but based on the recommendations from the American Academy of Ophthalmology, this dosing has been dosed down in recent years to 5 milligrams per kilogram real body weight. The maximal dose of hydroxychloroquine per day is 400 milligrams. So the studies that I've shown you here and other studies have shown that toxicity, cardiac toxicity has been associated more so with higher daily doses than those rates the ranges that I just gave you, between 5 milligrams to 6.5 milligrams per kilogram. And this is the same for retinopathy as well. And it's actually the retinopathy that has pushed the recommendations in terms of how a hydroxychloroquine is dosed. So higher doses definitely have been associated with greater cardiac toxicity, looking at the systematic review I showed you earlier.
Thank you, Dr. McGee. And another question, for lupus patients who have severely reduced ejection fractions of unknown etiology who are on hydroxychloroquine. We know that hydroxychloroquine can cause a cardiomyopathy. Should we hold hydroxychloroquine in those patients?
That's a very good question. Certainly we'd have to evaluate each patient on a case-by-case basis to determine other etiological factors. And that's the issue with diagnosing cardiac toxicity attributed to antimalarials in lupus, because there are many confounders. There is, the baseline traditional cardiovascular risk factors and the population-based risk for cardiovascular disease that still applies to patients with lupus. So we have to try to determine the etiology. It is very hard to determine that this is likely to be hydroxychloroquine induced because the tests that are definitely confirmatory are invasive. We can use some surrogates, for instance, if a patient has an inflammatory myopathy. The systematic reviews show that if patients have an inflammatory myopathy, elevated CK, so their skeletal muscle is actually involved in the disease, they are likely to, there's a higher probability that this is a hydroxychloroquine-related cardiomyopathy because of the similar pathophysiology that occurs, and there was a correlation shown in the systematic review. We would have to do invasive tests. So cardiac MRIs would be helpful, but not even a cardiac MRI can tell you definitively, because the changes in hydroxychloroquine-related cardiomyopathy can look like that which you see in myocarditis, the ventricular hypertrophy, the late uptake of contrast. The definitive assessment is really endocardial biopsy, so cardiac biopsy. And this has been done in several case series, and it confirms a specific pathological finding of accumulated vacuolization in the myocytes and the accumulation of certain proteins called curvilinear bodies. So the short answer to this is that if you've excluded all the possible causes and you don't have access to definitive investigations, then it is worth, it should be held, certainly as a consideration.
And that was an excellent answer, actually, because that's a tough question.
Yeah.
I would only add that it's not common.
Okay.
Right? Hydroxychloroquine-induced toxicity is not the first thing that should come to mind, I guess.
Right. Okay.
But it's a tough question, yeah.
All right. Thank you so much. And that is the end of our first question and answer segment. Thank you so very much to Professor Caricchio and Dr. McGee for their excellent presentations.
Thank you. Thank you so much.
Hello. Thank you so much, Drs. McGee and Dr. Roberto Caricchio, for an excellent presentations. I really picked up quite a bit. Coming up soon, we'll have a musical item from Dr. Jessica Yap. Just want to remind you that the YouTube is back up, right? And thank our technical producer here, Miguel Manning. We are locked in at our location with Dr. Desiree Tullery, myself, and the production team to make it possible for all the viewers worldwide. So Jessica Yap will be coming up soon. The Facebook is on still, and we want to thank our sponsors again, main sponsors, the National Health Fund, Dr. Reddy's, IPCA, Facebook is on still, and we want to thank our sponsors again, main sponsors, the National Health Fund, Dr. Reddy's, IPCA, Wisinco, Imagination the Gleaner, Author Channel, Eziram, our production. Thank you very much. So we're queuing up for Dr. Jessica Yap. And we can see our sponsors, Ezerum, Auto Channel, The Gleaner, Imagination, Dr. Reddy, IPCA, Bowenringer. Okay. Sponsors, Ezerum, Auto Channel, The Gleaner, Imagination, Dr. Reddy.
So, hello everybody.
Thank you, Dr. Jessica Yap, for this lovely piece, always so very willing. Dr. Carol DeCoola will take us through the next session. Dr. DeCoola is the President Emeritus and the longest serving president of the Lupus Foundation. Welcome, Dr. DeCoola, nice having you, and I'll turn things over to you now.
Good morning. I hope you can hear me. It's raining here in St. Anne, cats and dogs. So this is good news for us because we depend on rainwater. We have no piped water here. So the rain is always very welcome. But it's also dangerous because the internet can disappear anytime. So therefore, I better go on with business here and introduce Professor Dr. David Eisenberg. Dr. Eisenberg is one of the heavyweights in the lupus research. He is professor of rheumatology at the University College London in the UK. He also is the a trustee of the arthritis research of the UK. Professor Eisenberg has published about anything you could publish in lupus. And in fact, a couple of weeks ago, I was reading up on abdominal problems in lupus, and whose article pops up, an article of David Eisenberg. I was not surprised. Professor Eisenberg is always around at lupus meetings, and in fact I remember him rushing from one lecture to the other because he has usually more than one to give. So therefore we are glad that today he is able to speak with us, and he will be speaking of precision medicine in lupus. Remember, we have basically most of our medications and treatments are not specific to certain abnormality, but he definitely will make his contribution and guide us into the precision medicine in lupus. Up to you, David.
So, hello everybody. I hope this is working. Welcome from London, a rather wet and rainy London. My name is David Eisenberg, and I'd like to thank Desiree for the kind invitation to talk to you in Jamaica. I am reminded of a lovely story of W.C. Fields, the old American comedian, who shortly before he died insisted that on his tombstone would be written the words, "On the whole, I'd rather be in Philadelphia." And I must say, on the whole, I'd rather be in Jamaica, but I'll do my best with the technology that we have. Okay, so now I have got the disclosures to show you, the companies that I have supported over the years. And I'd like to tell you that lupus is one of those diseases which is everywhere. You go to the Mother of Parliaments and you walk around the corner and you come to Lupus Street. You open your newspaper and you discover that the American singer Selena Gomez, aged just 21, has had a lupus transplant because of a lupus nephritis from one of her best friends. And you go to Tromsø, the only town in the Arctic Circle, and you think, I must have got away from lupus there, but no, because lo and behold, there's a boat called Lupus. Now, this picture was published in 1851 by Dr. Anton Elfinger, and it shows the very severe nature of the lupus rash in this young female over here, and you see the discoid-shaped rash of the young male. And it was a little bit later in 1874 that Moritz Kaposi was the first person to show that lupus could have an involvement of the internal organs, which is now very widely recognized. Now, I have a vision for lupus, and it's very simple. If we're going to improve the outcome for patients with better treatment, we need both to improve clinical assessment and to increase our knowledge of the etiopathogenesis of the disease. And I think when we assess lupus patients, we have to capture or to recognize that there are three elements that we're trying to distinguish. Activity, implying that there is something which can be improved. Damage, which implies permanent change. The difference between these two, for example, are patients with a hip pain. This may be due to synovitis, for which the treatment will be perhaps an intra-articular steroid injection, or it could be due to avascular necrosis, a complication of steroids, in which case a hip injection is the last thing you want to do. Then there's patients' perception of the disease, which is often widely different from what the physician thinks the patient is worried about. But first, a few words about monitoring. It's clearly very important with lupus to monitor patients regularly. In patients with active disease, it should be as a minimum every 1 to 3 months. In some cases, it may be every 1 to 2 weeks. With less active disease, it could be every 6 to 12 months. But clearly for patients on powerful drugs, close monitoring is needed, especially with regard to patients on immunosuppression and steroids. There's currently a debate going on as to how often patients on hydroxychloroquine need to have their eyes checked. The American College of Ophthalmology has proposed that no more than 5 milligrams per kilogram of body weight should be given of rituximab, and the implication is that after 5 years, these patients should be annually assessed, but it's still an ongoing discussion actually. Important also to notice that certain lupus antibodies are strongly associated with certain clinical features. So a lupus patient who is anti-Rho positive, one has to look out for photosensitivity and heart block. Those with antiphospholipid antibodies look out for clots and miscarriages. Very high levels of antibodies to DNA, especially if they are IgG, are strongly associated with renal disease. But we also have to be mindful of comorbidities. Atherosclerosis is clearly increased in lupus patients. If you're a woman and you're between 35 and 44, your chances of having a heart attack are increased by 50 times for reasons which are not very clear. The steroids that we use to treat our patients induce osteoporosis and the above mentioned avascular necrosis. Infection, clearly a problem with patients on immunosuppression. But the story around cancer is rather interesting and a little trickier in a sense. There is no doubt, I think, that non-Hodgkin's lymphoma has a weak but definite association with lupus. In contrast, there are certain cancers, breast cancers, ovarian cancers, and possibly cervical cancers, which are reduced in lupus patients. And this, of course, is interesting because these are the cancers of women, and yet 90% of lupus patients are women. And we still don't know, we don't have a simple answer to that paradox just yet. Now, the Doris group of investigators, organized by Ronald van Vollenhoven, who's now based in Amsterdam, came up with a series of treat-to-target initiatives, which obviously helps the idea of precision around the targeting of our drugs for lupus patients. And I want to go through the recommendations of this group in some detail. The treatment target should be the remission of systemic symptoms and organ manifestations to achieve the lowest possible disease activity, because there's no doubt there is a continuum between disease activity, damage, and death. So you have to stop that continuum right at the start by controlling the disease. Prevention of flares has to be a particular goal and should be looked for whenever you can manage that. It's not recommended, in contrast, that patients who are clinically asymptomatic, even though they have abnormal serologies, should be treated. Those sort of patients I would give the hospital clinic number to, or my secretary's number to, and say, look, your antibodies to DNA are high, your complement C3 level is low, you may flare, it's not certain, but you might do. If you think you're flaring, please call this number and we'll see you sooner than your supposed or your planned next outpatient appointment. And since damage predicts further damage, prevention of damage accrual has to be a major therapeutic goal here. Factors which negatively influence health-related quality of life, such as fatigue or pain, also have to be addressed. And the early recognition and treatment of renal involvement in lupus is strongly recommended. This is one of the most worrying aspects of systemic lupus. For lupus nephritis patients, induction therapy is likely to last for at least 3 years of immunosuppressive therapy, and the maintenance will be even longer, actually. So lupus maintenance treatment, especially for steroids, should be to use the lowest possible dose of steroids for the shortest possible period of time. Patients with antiphospholipid antibody syndrome, and about 30 to 40% of lupus patients have the antibodies, and about half that number, or between a third and half, have the clinical features. Very serious because it causes serious morbidity and possibly even mortality. But irrespective of other treatments, consideration should be given to the use of antimalarials. They seem to be very effective, almost whatever the lupus feature, from skin rashes and fatigue to renal disease. And relevant therapies adjunctive to treatment with immunomodulation should also be used. Now, this was a very interesting treatment algorithm study proposed by some investigators and published 3 or 4 years ago in the United States. 69 experts approached, and just over half agreed to respond. And their responses were based on 16 different clinical scenarios in which they were asked to suggest how best to treat patients. So for patients with constitutional symptoms, the first line of treatment should be hydroxychloroquine. To some extent, low doses of steroids and possibly immunomodulation of a mild variety, such as azathioprine, may be required. If that fails, mycophenolate, and if that fails, rituximab or belimumab may be useful. For patients with widespread discoid lupus, hydroxychloroquine and steroids are likely to be used. We may need to add in additional immunosuppression, and mycophenolate or methotrexate have also been widely used there. For polyarthritis, again, hydroxychloroquine and steroids, methotrexate particularly valuable, and in our experience, rituximab can be very useful for these patients. For patients with thrombocytopenia, invariably steroids are going to be used, and those steroids will also be added to in the form of azathioprine or mycophenolate. But again, rituximab, intravenous cyclophosphamide, or IVIG can be very helpful for these patients. For lupus with APS, warfarin or low molecular weight heparin, to which we might need to add aspirin or dipyrimidol, platelet aggregate inhibitors, and vitamin D. For patients with significant mononeuritis multiplex, an important, though fortunately relatively rare, CNS manifestations of lupus, steroids and intravenous cyclophosphamide can be used. Alternatively, rituximab, IVIG, or even plasma exchange has been used. For nephritis of the proliferative type, either the type 3 or the type 4, steroids together with mycophenolate, which can be interchanged with cyclophosphamide and or rituximab, are widely used. For patients with membranous disease, again, steroids and mycophenolate, possibly switching to azathioprine if the patient wants to become pregnant, or IV cyclophosphamide and rituximab can all be used. Now, in order to understand the immunopathology of lupus, you have to understand what is going on in terms of cell destruction. And for here, the big advance that we've managed to work out a better understanding on in the last few years is the understanding of the nature of the immune response. And this starts with the normal program of cell death or apoptosis, which gave us some understanding of one of the key mysteries of lupus, which is why lupus patients are more likely to develop antibodies against structures buried deep inside the cell nucleus, deep inside the cell. It never made any sense, but apoptosis explains it. You don't need to be a great histologist to see the difference between the patient, this viable cell on the left-hand side, and a patient undergoing apoptosis, because the dense matter that you see over here is principally nuclear material, which is getting to the surface of the cell, where it will eventually form a little surface bleb. And it was the work of colleagues in Baltimore over 25 years ago, which first gave us an understanding. This is the work of Anthony Rosen and his wife, Livia. They took human keratinocytes and they subjected them to ultraviolet radiation, which encourages apoptosis. And they showed that in these larger apoptotic blebs could be found nucleosomes, which is to say DNA and histones, together with a larger Rho fragment, LAR molecule, and the SM molecule. In the smaller molecule, we found the smaller Rho particle, together with some other structures, including, interestingly, fodrin, which is found, or antibodies to it, are found in patients with Sjogren's, and Jo1, the antibodies to that, are found in patients with myositis. Now, under normal circumstances, apoptotic cells are very efficiently removed by their phagocytes through a complex mechanism which incorporates the use of the C1q receptor. We know that apoptosis is driven by infection and irradiation. So normally an apoptotic cell will be identified and removed efficiently by the phagocytes. And it seems that lupus is a disease in which there is inefficient removal of the apoptotic cells, leading to the spinning out over into these ruptured superficial surface blebs of structures such as nucleosomes, meaning that DNA and histones, which are not usually found free in the serum, the blood of patients with lupus, is found to be free. It is picked up by antigen-presenting cells or B cells working in that fashion. They interact with T cells, and they in turn stimulate other B cells to produce plasma cells, which will produce antibodies against these fragments found in the circulation, such as DNA and histones. Now, 10 years ago, showing this diagram, I was full of confidence that one of the many monoclonal antibodies which we were producing would produce a great series of winners in terms of therapeutic treatment for patients with lupus. and that we could use this very precise targeting of individual components of the immune response to move forward therapeutically in the same way that we had done 20 years ago with the treatment using TNF-alpha blocking drugs in patients with rheumatoid arthritis. In particular, you'll see around the B cell, we found a large number of potential targets: the CD20 molecule, the CD22 molecule, the interleukin-6 receptor, which links the T cell and the B cell, or perhaps the antigen-presenting link between that and the T cell, which abatacept was known to block, or the immune-enhancing elements, which incorporates interferon alpha, for which several different monoclonal antibodies were developed. And it's been such a disappointment over the last few years to see that this is our hopes have not been realized. And indeed, a few years ago, when I put this slide together, it was extremely depressing to note the rituximab, which blocks the CD20 molecule, eprituzumab, which blocks the CD22 molecule, and abatacept, either combined with mycophenolate or cyclophosphamide, all had gone on to large clinical trials, and they had all failed. And I think anybody putting this slide together under normal circumstances will be entitled to reach out for their citalopram, their antidepressant. But me, I'm not going for antidepressants so much. I turn in this situation to music. And the song which came to my mind, obviously, was Elvis Presley's Heartbreak Hotel. But I don't think Elvis Presley, looking at a graph like that or rather at a table like that, would have sung the original words of Heartbreak Hotel. Rather, he would have sung the following: well, those lupus trials failed. Another one bites the dust. The wolves of hell are waiting for me in the Heartbreak Hotel, where I'll be in good company. Yes, in good company, and so depressed because my patients could die. But ladies and gentlemen, I'm happy to tell you that this very depressing song I can now put to one side, because we are beginning to see some successful trials and studies in patients with lupus using monoclonal antibodies. Here, for example, belimumab, which blocks the B-cell activating factor known as BAFF or BLIS. And tabalumab, two big clinical trials, one of which did meet its primary endpoint. Even though with blisiblimab, we did not see success, with atacicept, which blocks both BAFF and APRIL, two B-cell activating factors, although the safety committee prematurely and, in my view, incorrectly terminated the higher dose arm, this has shown some very encouraging results. And here's the data, the original data on Benlysta. Here's the BLIS52 trial, in which we see the belimumab given either as 1 milligram per kilogram or as 10 milligrams per kilogram compared to the placebo reach these highly statistically significant endpoints at 0.03 and 0.006. And in the BLIS76 study, we see another successful result with the belimumab at 10 mg per kg being statistically significantly different to the placebo. And this early work has been supported by a trial from China and the Far East, in which you see the results using a complex combination of response indicators, the SRI-4, or the SRI, or the Slina-Cine greater than 4 points, or the time to first severe flare, where we see that the placebo here in the gray compared to the belimumab is clearly doing better in each of these particular aspects. So that we know that belimumab, Benlysta, does work in significant numbers of patients, but principally with skin and joint disease. And it's only recently that it's been demonstrated to be effective in some patients with nephritis. So an update on Benlysta would be this: it was approved in 2011 for the use of lupus patients with skin and joint disease. In the UK, it was approved by NICE, but under very stringent conditions. It doesn't have a complete carte blanche, and it's going to be reviewed after the first 300 patients have been treated. But long-term studies importantly have shown this to be a very safe drug. Now, what of interferon alpha, which is the other, I think, quite successful approach? We know that two of the trials using sifalimumab and anifrolumab have met their primary endpoints. The company which makes anifrolumab, AstraZeneca, are proceeding with further studies in anifrolumab. In contrast, rontelizumab was not successful, but the results with anifrolumab have been so strikingly successful, as I'll show you, that the company is very happy to proceed. Now, going back to rituximab, which I've mentioned a couple of times, and which I and my colleagues were the first to use in lupus 20 years ago. And this was based on some work done by my colleague Joe Edwards, who'd introduced rituximab for the treatment of rheumatoid arthritis. This drug, although it failed those two big clinical trials, we suspect this is because of the clinical trial design, is now recommended by the American College of Rheumatology and by its European equivalent for the treatment of lupus nephritis. It is approved in the UK by NHS England, an organisation which recommends treatment for rare diseases. It is widely used for many aspects of lupus treatment, but remember, it's not a cure. It is of no help in approximately 10% of patients, and one has to be mindful of the dangers of hypogammaglobulinemia and allergic responses. My experience with this drug is this. Anemia and thrombocytopenia will begin to improve within 2 weeks. Arthritis will take a little bit longer, 1 to 2 months, the same sort of period that pleurisy or pericarditis may take. Skin responses are more variable, and I'll tell you about that in a second, and renal disease may take several months. But let me give you some examples. So here is a patient who came to see me nearly 15 years ago. Terrible disease, as you can see, subacute cutaneous lupus. And this, ladies and gentlemen, is what she looked like after 1 year on an average of 40 milligrams of steroids. 6 months accompanied by azathioprine, 6 months accompanied by methotrexate. That's what she looked like. And yet 4 months later, after she got a combination of rituximab with some cyclophosphamide and a little bit of steroid, a fantastic improvement. She was to flare 3 or 4 years later when we gave her just rituximab and steroids, and she's remained in good health for the last 15 years. This was a patient who came originally from Slovenia, but was married to an American serviceman serving on the Laken Heath base just outside Cambridge. And this is what she looked like after a couple of months on steroids. Clearly a pretty horrible form of lupus, very, very aggressive disease, confirmed also on her scalp, where you can see this very nasty rash with profound alopecia. And yet 3 to 4 months after treatment with rituximab and with a little bit of cyclophosphamide, a fantastic improvement, as you can see. And it's not just the skin that improves, although let me just emphasize that the different aspects of lupus as it affects the skin are affected differentially. Patients with acute lupus over here and patients with more non-specific findings seem to do particularly well. In contrast, patients with subacute disease and chronic cutaneous disease do less well. But nevertheless, we've seen with these patients some spectacularly good responses. But here's the response of the kidney. My thanks to Professor Ronald van Vollenhoven. And you can see patients with lupus nephritis, proliferative disease over here, very marked disease. And yet 6 months later, the patient is looking fantastically better. And ladies and gentlemen, it's not just me who's saying this to you, it is also the BILAC group. So here we see in a group of very hard to treat patients, around 178 patients actually, at 6 months, over half of these patients who didn't respond to conventional treatments are responding beautifully to when they were given rituximab together, in some cases, with cyclophosphamide. So the treatment that's been used by us and by others has now been taken to a new kind of approach by my colleague Liz Lightstone, who's a nephrologist based at the Hammersmith Hospital in London. Her view was this. She said the people at UCH have been using rituximab at the end of the lupus journey when this combination, where the conventional combinations of treatments have failed. If it works at the end of the lupus journey, why not use it at the beginning of the lupus journey with a particular aim of trying to avoid the use of steroids, which cause all these nasty side effects. So this paper, which was now published 7 years ago by Liz Lightstone and her colleagues, took 50 patients with lupus nephritis, histologically proven lupus nephritis. No ifs or buts, this was the real thing. They were given 2 shots of rituximab, followed by some mycophenolate. They were not given any oral steroids, and they were followed up for 2 years. And amazingly, this, when you think that steroids have been used to treat lupus for some 60 years, only 2 out of these 50 patients required any oral steroids during the follow-up over this next 2-year period. And here's some of the data which I think is extremely remarkable. After 1 year, 50% of the patients treated in this way have gone into complete remission, and it's about 85% of patients go into complete or partial remission. Again, just to emphasize, after 2 years of follow-up, only 2 of these patients required any oral steroids. Now, I thought that this was a very remarkable way to go, and I just tried to introduce it into our own treatment of patients with lupus at University College. And we identified 16 patients who we've treated in this way in the past 12 years. And these patients have been followed for periods of up to 6 years. And we matched these 16 patients with 3 other patients for ethnicity, sex, age, clinical features, and disease duration. We used the BILAC system to capture disease activity. We looked at their steroid requirements. And as I said, we followed them for up to 6.5 years and compared them to these conventionally treated patients. First of all, we wanted to see if this was effective, and it clearly is. In the B-cell depleted patients, these 16 patients, only 50% have flared compared to 70% who flared using conventional treatments. And the numbers of flares are also slightly smaller in the B-cell depleted group compared to the conventionally treated group. So it's clearly working. But is it saving on oral steroids given to these patients over longer periods of time. Serologically, it's having a great advantage. Here we can see the DNA binding in an assay with the upper limit of normal is 50. The DNA binding is falling in this B-cell depleted group from over 1,000 units to 194. The sedimentation rate falling by 70% at 6 months, and the C3 being normalized in 7 patients. But I want you to look at these 16 individual patients. In pink, over here and here and here, you see the patients given the B-cell depletion. And here, for example, are the 3 controls. So this patient gets a little bit, as they all do, a little bit of steroid when the rituximab is given. But over a period, I think, 4 years of follow-up, this patient had a total of 250 milligrams of steroids compared to the controls who had a total of 15 grams of steroids. And here's a patient that will take it over here, patient number 11, again gets 250 milligrams compared to the controls who are getting an average of nearly 10 grams of steroids. So there's no doubt that this is a very interesting way to go. Now, I want to point out that there are some interesting new developments in this field of blocking CD20. We recognize 2 types now of CD20 molecule, and it really depends upon the way in which these monoclonals are able to redistribute the CD20 on their surface, and in particular, some differences in the way in which apoptosis is observed with the CD20 molecule. So the rituximab is known as a type 1 CD20 blocker, but other more fully humanized monoclonals such as obinutuzumab, which we now have some experience, are actually the so-called type 2. Some interesting developments there. But let's focus again on interferon alpha, clearly playing a very important role in linking a number of cells and molecules in patients with lupus. I want to emphasize that some of the monoclonal antibodies to interferon alpha are blocking it when it's free molecule in the serum, but anifrolumab is actually blocking the receptor. Now, the SRI responder index is a conventionally now widely used combination of a global score system, the SLEDAI, the BILAG system, which is capturing and distinguishing different sorts of improvement, and a physician's global. The BICLAR utilizes the same indices, the BILAG, the SLEDAI, the BILAG, the SLEDAI, and the physician's global, but in a slightly different way. Now, here's an example of the way in which we see the use of these responder indices using anifrolumab. Now, this particular patient group, the patients were distinguished into those having interferon high message in the cells compared to low. Here are the placebo-treated patients, and here are the patients given the Benlysta either in the lower dose or in the high dose. And you can see that the delta, the gap between the placebo-treated patients and the anifrolumab-treated patients is around 20%. It's lost completely in the interferon low patients. And this gives us a very useful guide into the precision medicine, which I was discussing earlier on, because clearly this looks like a good way to go in patients who've got a high level of the message, but it probably isn't going to work in patients who have a low level of the message. Now, that was the endpoint in the trial, which was the SRI-4. Looking at a series of secondary endpoints, we also see the value of using interferon or antibodies to interferon in the patients with high levels of the interferon message in their cells. And this is just to show you the same thing with the BICLAR. So in this, where we're looking for the responses, the primary responses using BICLAR, we can see the placebo-treated patients over here, and we can see it about 20 points higher, even higher actually with the 300 milligram group. We see fantastically different responses, improved responses in the patients given the anifrolumab. And it's certainly much more striking in the interferon high patients compared to the interferon low patients, where you could hardly distinguish the 3 graphs. So there's now bad news and good news. In a phase 3 trial, what I showed you before was the phase 2 trial, the so-called TULIP-1 trial. The primary endpoint was not met. But the investigators noticed that in this TULIP-1 trial, that patients assessed using the BICLAR did meet the primary endpoint. So the results of the TULIP-2 trial were switched to the BICLAR endpoint, and they did meet the primary endpoints, especially with regard to the skin, notably and especially in those with a high interferon signature. Now, there are other ways to go, again, looking with precision at particular molecules or approaches. I've hinted at the fact that rituximab might cause some problems, allergies, because it's a 20% made from a mouse protein. We now have available fully humanized CD20s, fully humanized anti-CD20s. We can also block BAFF and APRIL, as I've suggested. We can block the CD40 ligand. We can block the Fc gamma beta receptor. And there's a considerable interest in the use of Bruton kinase covalent small molecule inhibitors. And a very interesting molecule called Lupusor is a peptide which blocks autoreactive T cells. And that's going into a second phase 3 trial. We have JAK-STAT inhibitors being tried and various small peptides and low-dose interleukin-2. So in conclusion, ladies and gentlemen, the mortality from lupus has significantly improved in the past 50 years. And we're moving from an era of serendipitous descents, introducing new therapies on the basis of far more rational approach with much more precision. Unfortunately, the successful use of biologic drugs in lupus lags way behind that for rheumatoid arthritis and psoriatic arthritis by about a decade. The early open label success with rituximab was not followed by clinical trials which met their endpoints, and yet the wide body of evidence and wide body of experience, tens of thousands of patients have now been treated with rituximab because it clearly does work, and indeed it works to the data that's been collected has convinced the ACR and EULAR to approve it in the use of lupus nephritis. Benlysta met its clinical endpoints and is approved by the FDA. It works for skin and joint disease, and we now know that there's some evidence that it works in lupus nephritis. Very encouraging results have also been published using atacicept, which blocks the BAFF and APRIL. Ladies and gentlemen, we await more and more successful trials of biologic therapies in lupus, and more thought, I haven't had a chance to go into this today, but more thought needs to be given to the design of clinical trials. And interestingly, the first combinations of biologic drugs in lupus are underway. In my own hospital, we've recently combined Benlysta and rituximab, and the results of that trial will be out in a matter of weeks. And the use of biological therapy in lupus patients at the time of diagnosis needs to be tested more formally. So if I could sum this up for you, ladies and gentlemen, the last 10 years has really seen what I would call the situation of being past imperfect, future tense. But I believe that the use of precision medicine is very important, and our monoclonal antibody therapies will come true. And I think if I was a betting man, I think the use of humanized anti-CD20 and antibodies which block interferon alpha are going to have a very big part to play in that. And finally, my thanks to many colleagues who've helped me very much over the past 2 decades to make this feasible. Thanks very much for listening. Thank you.
Yes, thank you very much, Professor Eisenberg, for this very interesting presentation, which give us all hope that soon more therapies are needed. As we all know, in rheumatology, there is no one medication suitable for everybody, so the more, the better. I see Professor Eisenberg wants to get questions, but I don't know how to see the questions. Could Dr. Tellerid, could you probably ask the questions? Can't find the questions.
I'm on. Thank you. Thank you, Professor Eisenberg and Dr. Dakula. We're just trying to get the questions coming in on the chat, but a very informative presentation.
Thank you.
While we wait, I just want again to thank our sponsors, National Health Fund, and most of you would know that it's a well-run government agency that offers vastly discounted drugs for many diseases. So we're very grateful and thank them again for making this possible. We have Dr. Pardon me? Okay. I don't know if we have the questions yet. Some comments are coming in. It says from Claudette Martin to everyone, thank you, Dr. McGee. Always inspiring to listen to Professor Eisenberg. Thanks very much.
Thank you.
From Sheila Campbell Forrester, thank you for this update. Excellent presentation coming from Makisha Archer to everyone. And Kimberly Scarlett. Commendations. Trying to work with the technology, right?
Maybe I could ask Professor Eisenberg a question while we're waiting. David, you're treating patients with rituximab. You're giving them a little steroid dose. This is people who never were on steroids. What about people who were on steroids? Can you take these steroids away with the rituximab treatment?
Okay, Carl, so that's a very interesting question. It's good to see you, by the way. So we started off back in 2000 using this approach, B-cell depletion, for patients who'd failed conventional therapies, i.e. they'd had lots of steroids, they'd had lots of azathioprine, cyclophosphamide. And we're moving now to offer patients newly diagnosed the prospect of being treated for their lupus without using any oral steroids. That was the idea of Liz Lightstone. We've copied that, and it certainly works. So I've now treated approximately 20 patients in this way. And when a newly diagnosed patient presents herself to me, I give her a choice. I say, look, you can have the conventional treatment, which is steroids, azathioprine, mycophenolate, hydroxychloroquine, or we could try to treat you without giving you any oral steroids at all. We'll give you 2 shots of rituximab. You get a little bit of intravenous methylprednisolone to prevent any allergic responses, but that's all you're going to get. We're going to try and treat you with either azathioprine or mycophenolate and hydroxychloroquine, and we'll follow you up. And as you see the data, some of those patients, many of those patients actually have done really extremely well. And what's particularly striking is the saving over a period of many years compared to conventionally treated patients in the total amount of steroids these patients have. Now, I think this is important because the work of Murray Urowitz in particular from Canada has shown us that the damage that occurs in lupus patients is very much driven by steroids. At least 30 to 40% of the damage seems to be related to steroids, which are usually oral steroids. So if we can avoid that or reduce that or minimize that, that I think can only be a good thing. And the interesting aspect of the last 3 or 4 years, which has developed, is the introduction of the fully humanized anti-CD20s, which take away the allergic response that was an issue with, or is an issue with rituximab. It's an unexplained, mysterious thing that if you look at the numbers of allergic responses to rituximab in non-Hodgkin's lymphoma patients, it's about 1%. In rheumatoid arthritis patients, it's 3 to 4%. In lupus patients, it's 10 to 12 to even 15%. We don't know why it's so much higher in lupus patients, but it would be great if we had a widely available, reasonably cheap, fully humanized anti-CD20. We've used recently obinutuzumab, and that's looking very good. And as some of you will know, it's met its endpoints in a phase 2 lupus nephritis nobility trial. And the company who make obinutuzumab are now moving to a phase 3 trial for lupus nephritis and non-renal lupus. So that may be the drug of the future. I'm hoping so.
All right, here are some other questions. When you retreat people for the second time with rituximab, what is the interval? 6 months, 1 year?
Okay, So again, a very interesting question, and we do it very differently for patients with rheumatoid arthritis from patients with lupus. And I think I have a slightly philosophical issue here, because I think with rheumatoid arthritis, I think of it as a disease which kind of grips you and doesn't let go, whereas lupus is obviously characterized by flares and remissions. So we do not have, unlike our rheumatoid patients, where we would routinely give them repeated doses of rituximab every 6 months, 9 months, 12 months. Lupus, completely different. I've now treated 180 lupus patients with rituximab out of a total cohort of 750. But I can't say to you that there is any pattern for those 180 patients for the repeating doses. It may be after 6 months, it may be after 6 years. It's very much dependent upon the clinical features and the flare rate in those patients. So it's quite different from our rheumatoid patients.
Okay. Now there is a patient who is worried about hydroxychloroquine because she has been on it for 4 years and she is worried about the eye. Is there any alternative to it?
Well, I would want, first of all, to reassure her that provided she's taking the recommended dose of, let's say, 5 to 6 milligrams per kilogram, the chances of her getting any eye disease within 5 years are close to zero. Now, the American College of Ophthalmology caused quite a stir about a year ago when they came out with their recommendations of 5 milligrams per kilogram, which they said was based upon a figure of, I think it was 7 to 10% of patients on hydroxychloroquine getting the retinal problem. I must say our figure is much lower, and I discussed this recently in the BioLab group, and their figures, most of my colleagues, much lower. One may be as high as 2%, but generally most groups report 1%. In 1% of patients do you see the eye problem, and that's after a minimum of 5 years of treatment. So I don't think you're going to see any eye problems after 5 years. And if you keep to the 5 milligrams per kilogram, I think you can give it for 10 or 15 years without any problems. My personal view is I do the major test is at 5 years, and then every 2 years, approximately up to 10 years, I'll get the eyes repeated again, and then it's an annual assessment after each year. So after 10 years, it's annual, the assessment. And doing it that way, I think the chances of missing anything in the eye are very, very slim.
All right, good. Here's a patient who asked if she should be concerned about D-dimer levels, which are very elevated. Does she need to do anything else?
That usually links to the presence of clotting problems. Just as a de novo thing, it would be a rather odd finding. I mean, clearly she must, I assume, be seeing her physicians who presumably will be looking for other medical issues. That's something certainly to discuss with her physician and to determine whether or not there are any underlying clotting problems.
All right. Now, last question. Do you believe that these biologics are going to be less expensive over time? Or because most of our patients here in Jamaica, I don't think we would be able to afford it.
Okay, so the cost has already started to come down. Rituximab came off patents several years ago. And in the UK, the cost of rituximab, 2 shots, was £5,000. But with the biosimilars that we use, Truxima, for example, it's half that. And that number is continuing to fall. The challenge, of course, is that with the newer drugs, such as obinutuzumab, the cost will undoubtedly will be high if it does get to the market. So the price of rituximab biosimilars is already substantially cheaper. But the cost of the fully humanized ones, I'm afraid, is going to be expensive for some significant amount of time.
Okay. Thank you so much for your
Great
time.
pleasure. Good to see you.
Okay, good. Okay, bye-bye. All right, now we're going to go on because we are already behind schedule with Dr. Rachel Lowe Jones. She is a consultant nephrologist based at the Mandeville Regional Hospital. And she is a graduate from the University of the West Indies. She also did her postgraduate studies in internal medicine and then went on to St. George's University Hospital in London, not to study rheumatology, unfortunately, but to study nephrology. And she is speaking today on a very important topic, the patient-centered research in lupus. Okay, up to you, Dr. Lowe.
Thank you, Dr. De Coulier. I'm just going to share my screen. Can everyone see my screen? Dr. De Coulier? Okay, I guess I'll begin. Good day, everyone. And I would like to give a hearty good day to our lupus warriors as well. Thank you. I would like to thank the Lupus Foundation of Jamaica for inviting me to speak this afternoon on a slightly different spin. Really, we're focusing on patient-centered research in lupus. So it's a bit of a non-clinical topic, but there are some clinical aspects to it as well. From the previous presentations, I want everyone to know and realize that lupus is quite a multifaceted and complex disease. It has very bad clinical outcomes, especially in persons of color. Now, these persons have been traditionally underrepresented in clinical trials, not just lupus, but overall trials. Many reasons for this that we can get into. There's also been, these persons have also been noted to not be as active in their healthcare, or has a high incidence of non-compliance or non-adherence to their medical treatment. This was, and so this term of patient-centered care or patient engagement was basically publicized in the late 1980s and early 1990s at the advent of HIV coming on stream, and cancer patients who basically were saying, look, we need greater patient representation and shared decision making because a lot of these patients were dying. So we want to get into what exactly is patient engagement and how can we engage our patients to be more involved in their healthcare, and for us as healthcare practitioners to assist in this shared decision making. So what is patient engagement? The Institute of Medicine gives this definition as providing care that is respectful. Sorry, 1 minute, let me just put it on. Right. That is respectful and responsive to the individual preferences, needs, and values of our patients, ensuring that the patient values guide all clinical decisions. I'm sure many of our lupus warriors and regular patients have gone to the doctor and not quite satisfied with the outcome of that visit or that meeting, right? Sometimes they're coming to hear some, further information on their disease, and they're not satisfied. So they're seeking additional information that the doctor is just quite not getting across, or they sometimes don't understand. We all know what the patients need, right? However, there's a stark difference as to what they actually receive. So one of the things we have to do is build trust among the patients and among also as well as in the healthcare industry. This has been quite difficult recently because of the whole COVID pandemic. For example, just vaccine-related deaths. So it's something that we're going to have to try and get our patients over. There's also many additive problems to involving patients in research or getting them more involved into their care. One of the biggest things we've noted is that the patients really don't understand their illness. So they come in for a brief visit, and we're basically writing up a prescription before we're even examining them sometimes, or hearing what has been going on in their family home, right? There's also well-known healthcare inequalities. Many of the patients can't even afford to come to their visit, right? A lack of availability of transportation. A lot of our patients locally don't have basic medical coverage, although we do have a so-called quote-unquote free healthcare system model in Jamaica. There's a lot of things that are not available in the public health setting. And so a lot of these costs the patient and their caregivers have to bear. Many patients have inadequate knowledge of their government health resources. Many of them don't know the other supportive areas to get help. And many times over the years, research has been prioritizing healthcare provider outcomes, such as death, hospitalization, side effects of drugs, what's all the new and exciting drugs, instead of really concentrating on what the patient feels is important, right? Now, just in Jamaica alone and in the Caribbean, we have, although our culture we have a particular culture, but within our culture, there are also microcultures. And each of these microcultures have particular nuances, right? And we have to be cognizant of that when these patients come to us asking for our help or trying to engage them to comply with certain medications or treatments. Well, a strong primary care health system is a must, right? What is primary health care? It's the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing the large majority of personal healthcare needs and developing a sustained partnership with patients and practicing in the context of family and community. And I want to draw upon the last two items in that definition, family and community. The patients can't do it on their own. So it needs a whole community effort, right? The basis of forming a strong patient-centered care and introduction into research involves a very strong primary healthcare system within any society. However, the healthcare providers also have to have access and be given the tools and resources to adequately carry out their roles. As we can see, we're trying to keep the patient at the center of it all, but there's an overlap, right? As we said, it's not just the patient. We need help from the community leaders, and of course, we need the supporting staff and to help support the increasing the knowledge of staff to help care for these patients. Because all in all, it will result in improved healthcare outcomes that are patient-specific, which is what we want to emphasize. And we want to emphasize where the outcomes really, the outcomes truly matters to patients. As Professor Eisenberg had mentioned about precision medicine, it's the way of the future, right? Genetic testing is becoming the norm. Not as much locally, right? But there have been the genome-wide study out of the UK that has been doing genetic testing, not genetic testing, but genetic profiling of persons to create a large data bank. And this will help in diagnosing diseases that are from the prenatal stage, right, before pregnancy. There's also a push to remove race from a lot of calculators, as they're saying that this can be biased against the patient. For example, there's a lot of controversy right now in terms of the glomerular filtration rate in our kidney disease calculator. Removing race, as although these patients have been, our kidney patients normally have I should say Black patients normally have a higher creatinine and higher muscle bulk. We cannot use the GFR because sometimes it skews the outcome and the prescription treatment for these patients. Precision medicine is also moving into the formulation of national disease and genetic registries, and we're hoping that this can be formulated locally. We embarked upon a study to determine what is the knowledge base of nephrologists in terms of involving patients in clinical trials in nephrology. A lot of these patients, a lot of these doctors was quite surprising because it was taken from across a wide cross section from around the world. We had 177 responses from 45 countries. India had the highest response, but unfortunately, Latin America and the Caribbean had one of the lowest responses for existing patient involvement research trials, right? So these are their own doctors are not pushing research and the patient involvement in research trials. Now the trial that we had done, it was kidney focused, and we wanted to determine if there could be a more robust inclusion of patients in renal trials. A lot of low and middle income countries have extremes of healthcare, right? It's either they can afford or they cannot afford. And many previous older trials, kidney disease patients were left out of many of the trial designs just because of how severe their renal impairment was, which hindered, a trial of use of the drug. We found multiple barriers to patient involvement in research, right? We're going to go through patient factors, research factors, and system factors. Again, one of the glaring factors that we noted was that there was a lack of awareness of how to get patients involved, right? So our own doctors didn't know, how do we get patients involved? Most times they're taking patients directly from their own departments, from within hospital. But in getting the word out to get other patients, non-hospital patients, they did not know. They were also not given full information about what is required for the patient and public interaction, right? They were not prepared enough for this role. A lot of the research meetings that we were having, they did not, it wasn't scheduled according to the patient's needs. So sometimes, the patients had their dialysis days and, certain things cannot be changed. But we did not, we did not feel that the nephrologists were making that extra effort to accommodate patients on non-visit, non-clinical or clinic dates or dialysis dates. And a lot of the times patients who were involved in trials previously mentioned, he said, doc, I was involved in this study, I tried this drug, but I haven't heard anything. So patients are not being given feedback on study results or how their contribution was seen. A lot of them say they don't feel valued, especially if this involvement is perceived as tokenistic. Some of the research factors we found among the doctors was lack of knowledge about how to undertake meaningful involvement. Also, the perception that the patient and public intervention was too resource intensive, right? We had to actually finding the patients, contact, just something as simple as their contact information was difficult to obtain, or reliable contact. A lot of the researchers, the nephrologists mentioned that they didn't see the worth or impact of involving the patients in their decision-making in trying to formulate research. Again, there was an issue with the recruitment of how to recruit these patients, and they didn't understand the range of possibilities to involve patients in study design. Basically, they were saying it was just too difficult for patients to understand, so let us just get on with it, basically. Some system factors in terms of barriers to patient research was basically a lack of a system or protocol of how to recruit and engage patients. There was also a lack of funding to reimburse persons who lived with experience. There was also a lack of funding to reimburse patients' time and expenses. Payment of these patients for acting in clinical trials can be quite complex. And again, the resources to encourage patients and their families were not known or widely used. I wanted to mention that it's quite exciting times, as Professor Eisenberg had mentioned, because the European Renal Association and Dialysis and Transplant Association, along with EULAR, updated their lupus nephritis guidelines last year. And what they've listened to the calls, so they've added a more multidisciplinary approach since the 2012 guidelines. They've also shared input from nurses in the guidelines. So they sought the expertise of nurses because they were on the front lines, right? They also included input from the nephropathologists, because a lot of histological and genetic work has been taking place. But most strikingly in the guidelines that was updated was that they actually had placed input from patients, which was quite commendable to place in the guidelines. And their input was basically, how do we manage our comorbidities? It's not just lupus alone we're managing, it's not just lupus and the kidney, but a lot of them have comorbid conditions, hypertension, the steroid-induced diabetes, arthritis, right? So they also mentioned that they wanted things to talk about the disease-related quality of life. And these are the things that are left out of trials. Quality of life, functionality, and these things were updated in these guidelines, as well as they wanted further information on the natural course of the disease, as well as therapeutic options and side effects. So a lot of these things were added in the guidelines, and we're happy to report that patients' input was recognized and included. Just to reiterate what Prof. Eisenberg had mentioned, it was very exciting in the world of lupus nephritis, so lupus and the kidney. There were 3 positive trials recently released. Again, we are very excited because kidney and lupus disease, again, is a very complex and multifaceted disease process, right? And so what we found is that these 3 trials, testing these 3 new monoclonal antibody agents and calcineurin inhibitors, are basically a headway into treating patients where lupus affects the kidney. Also in these trials, I wanted you to note that, especially in the AORA trial, that they made a concerted effort to include patients that were normally underrepresented. So we had a lot of Hispanics and Blacks in these trials. Now, patient-centric models are now part of many healthcare landscapes, right? And what we need to do is to educate our patients, encourage them the best we can, empower them with the knowledge, constantly engage them to basically enhance their quality of life. Because what it all boils down to is their quality of life. We noted that in Picker's 8 Principles of Patient-Centered Care, where he felt these are the pillars of what healthcare providers and patients should strive for. A mutual respect for the patient's preferences. Again, coordinating and integrating care among a multidisciplinary team. For instance, Dr. Davis and I share a patient, and as much as possible, I try to coordinate the visit so that the patient doesn't have to have another blood draw. Because, you know, they come to clinic and say, Doc, I have to get another stick. So we try to coordinate with the other healthcare providers so that, you know, one less stick is a big deal. We want to provide them the information and education, and a lot of times during the clinic visits, we don't have enough time due to the amount of patient, the patient load, right? And this is something that can be worked on. The other pillar, physical comfort of the patient, emotional support from family and friends, involvement of family and friends. So many times patients, please bring someone to the clinic. Although it's COVID time now, at least have someone with a listening ear that you can hear the information, because sometimes you can't capture everything. We want continuity and transition of care. So especially in our pediatric populations, because we do have to manage patients as young as 12 in the adult clinics. And I want to speak to that. That could be very scary for a child to come to a clinic filled with a lot of adults, and to have, after being seen by their pediatrician for all these years, and now they're basically with all these adults. So transition care is also important, and we have to be mindful of that. And a lot of times we're not. And of course, access to care, which could be a big issue. How can we increase patient engagement in research? How can we get them more involved, right? There's a global communication right now among patients. Patients right now have WhatsApp groups, right? A lot of our dialysis patients have WhatsApp groups, and they WhatsApp one another, what's going on, what's the latest, why are you getting this medication, what is going on, right? So the use of social media to boost this has boosted global communication among patients. And similarly, among healthcare practitioners, the SoMe movement, which is social media, a lot of education, a lot of global transfer of information and education has also increased and helped to help healthcare practitioners find ways, innovative ways of trying to engage patients. Use of emerging technologies, incorporating healthcare innovation, right? There's a lot of persons wearing medical device, these wearables now, and these things can track patients and can help to support the healthcare practitioner in trying to get information from the patient. And of course, trying to develop a healthcare information system on a national level so that we all can be connected. Healthcare workers can be connected from one part of the island to the next. What else can we do? We have to set out appropriate individual and joint goals when we see these patients, right? Let them know that what they're contributing to in terms of research is something that is a game changer. Maybe it may not impact them now, but definitely generations down the future. A lot of times, again, there's a certain distrust when we approach patients and say, we have something interesting that we'd like you to try, or getting more involved in research. And sometimes you have to go to the community leaders and let them speak among themselves, show them the evidence, even share a meal with them. We also need patient advocates. We need our own patients who are actually suffering from these diseases to be represented, not just in foundations like the Lupus Foundation, but also on a more higher level through the ministry, through legislative, financial, and regulatory boards. It's only until patients are on a higher platform and is represented, can we also make headway in terms of support, not just for research, but for pharmaceuticals. We also, again, what else can we do? We need a national electronic health record system. This obtaining data at present is very difficult, right? A lot of the things are not, they're not on the electronic, they're not electronically, they're not even indexed, they're not how should I say, it's basically still a system where we have to be digging for the information. So it makes research gathering and research data collection very difficult. Getting a national program where everything is electronic, it would be a huge help. What else can we do? A lot of times patients are sitting in the waiting room, it would be a good idea to develop patient feedback surveys. This can help us find out what is it that we're doing right and what it is we're doing wrong. Some countries have feedback survey kiosks or just a little drop box, and this can help improve upon what we need to do and take us further into the future. So in conclusion, some persons are saying that patient engagement is not descriptive enough. We need something called, a better term, basically patient personalized medicine or patient empowered care. These are terms that put the power and the decision making to the patient and to prevent them from being having a passive role in their care, but a more active. I want to thank foundations like the Lupus Foundation of Jamaica, making it possible for patients to connect. They have a very strong patient support group and network, and patients and socials. And sometimes we need that to get out of our healthcare environment into a social setting to see what's going on, to throw our own ideas. Not just lupus, but we need patient-centered support groups among all our disciplines. Collaboration is key among all stakeholders. So we don't want anyone to be boxed in one type of treatment. Everybody is different. Everybody has a different genetic makeup. Lupus is a multi-complex disease, and we need to push forward in individualizing care to these patients, educating them about the therapeutics, and not just what is going on now, but let them know what's going on for the future, because one size does not fit all. I want to leave with a quote from Donald Berwick's book, that nothing about me without me. Thank you.
Thank you very much, Dr. Lowe. This was a very important talk, because it's only by reflecting on the patient and the patient needs that we make some progress, because we're taking sometimes things for granted. Every day we should have a question to see what we can do better. Now, I think there should be some questions, and let me see if there are. Not yet, not coming on. Now, while we're waiting for the questions, what do I do here now? Let me ask you, do you have any problems in your own setting that administrators of the healthcare do not understand the patients either, and are probably not so much accepting a new way of change or something like this?
Thank you for the question, Dr. Lupus. It has been challenging at times when you see that there can be a positive change, and sometimes something very simple can be done to make an impact on a patient's care or their visit. A lot of the times we're hampered by the fact that there is, quote unquote, no funding to implement change, but certain small steps can be done to improve patients' lives. So in terms of the getting support, I myself have gotten support in my setting, and I'm very thankful for that. And they're always willing to do more. However, it always comes back certain times to a budgetary constraint. But again, as I said, it doesn't always have to be about a budget. There are certain small things that we can do to make patients' lives better and improve their quality.
Okay, thank you so much. Ethical issues of research. How does the patient-centered approach deal with that critical issue?
Now, the medical, legal, and ethical aspects of research is something very important, and we need to have a national framework in place. For instance, kidney transplantation. When patients with lupus nephritis become end stage, we have to have a framework, right, of how patients are transplanted, or in certain decisions were being made. Recently, a country just passed, I think it was New Zealand, passed the law for euthanasia. And you have to have a very high level of medical legal transparency, protocol, and basically a framework to conduct things like that, as well as to conduct research. And once it's there, you know, hopefully that the ethical considerations don't hold back or delay the research process.
Do you have problems with ethics committee in getting approval, or not so much? And does it take long, or what?
Well, I haven't personally had any interaction with the ethics committee as yet, personally. But when I do, I will bring my feedback. Will give back my feedback.
Have you spoken to patients who have been involved in research locally? What do they think about their experience?
Now, I've been back recently, just recently, I returned last year, and we are starting to gather data and informally ask patients if they'd like to be involved. And a lot of them jump to say yes, because they feel like they're going to get a benefit from it. So you have to be very careful when you approach patients and let them know the full benefit and possible consequences of going forward.
All right, thank you very much. I think that will be the questions for you for right now. There will be lots of questions for the next time. Can I give the mic back to Cedric now, so that he can take over?
Thank you. I'm on? Yeah. Thank you very much, Dr. DeCooler and Dr. Raquel Lowe-Jones, for a very, very engaging, informative, and engaging presentation. Sheila Campbell. There's a question from Sheila Campbell. Very useful guidelines. I guess some of the ethical issues, including payment.
Does the research include levels of health literacy?
And does the research include levels of health literacy? Does the research include levels of health literacy? Do LK providers understand this concept, and is there a need for more training and health literacy? Dr. Lowe-Jones, I don't know if you're still hearing me. She can hear me?
Yes, yes.
Okay, thanks.
Now, that was one of the concerns when we did our research in terms of health literacy among patients. One of the things is that hearing all the big words, they were quite timid, as well as our own doctors were not able to explain what it is that they wanted from the patient in a way that is understandable at a level that they can make an informed decision. So there has to be a twofold team where the patient is basically guided through the initial, basically a general orientation as to the terms, what they mean in initiating any type of research, what they're expected to do. But there is, I agree, there is going to be some understand. There has to be some type of understanding for the patient to make an informed decision to partake in research.
Thank you very much. And thanks again, as I say, thank to both of you for this particular session. It reminds me of what Professor Albert Einstein said a long, long time ago. I don't want just to be known as a man of success. I want to be known as a man of value. And it speaks to me clearly that all our presenters, all the brilliant clinicians, rheumatologists, and all those since morning have given so much value in terms of your knowledge and your time. And I think Thomas Jefferson said that in another way, you must at least put back the equivalent in life of what you have taken out. And all of you have given so much more than what you have taken from life. And that is the essence of living. Okay? Thank you very much. Thanks, Dr. Zakula. Have a good day. I know you're still online, and Dr. Lou Jones. Just to give you a little bit of what will be coming up, we're going to have a little break for 5 minutes. A break insofar as we're going to show you a short video from the National Health Fund, which is one of our main sponsor. And then we will go into a very interesting talk by Dr. Michael Abrams after that. So if you see a short video on your screen, we haven't finished. We have lots more to go. Run to your fridge, get some coffee, and we're here with the production team, Alex and Miguel and Dr. Desiree Tollerida and myself. The four of us are locked down here, and I'm not a very technical person, so I'm very grateful for these two gentlemen. I would be totally lost, but thank you. So you're going to cue up the video now, Miguel and Alex. All right, and then we will come right back with Dr. Michael Abrams. Thank you again.
We all have partners at home, at work, at play. Partners give us the support we need to overcome life's many challenges, especially when it comes to our health. The NHF is a solid partner for healthcare in Jamaica, providing funding for the nation's health sector, discounts on medication for persons with chronic diseases, and promoting healthy lifestyles to help Jamaicans enjoy good health and a better life. NHF, your partner for healthy living.
The National Health Fund same-day card service is now in every parish at selected drugstore pharmacies. Now you may apply for your NHF card or JADEP card without the hassle of long trips. Take your properly completed application form to your nearest same-day card service location and your card will be ready within 30 minutes. It's now a lot easier to get your NHF and JADEP cards. For more information, call the NHF at 876-906-1106. The National Health Fund, your partner for healthy living.
Introducing Quick Prescript, the quick and easy way to fill your prescriptions from public hospitals and health centers. Quick Prescript kiosks will be available in public sector pharmacies across the island on a phased rollout basis. Here's how the kiosk works. Place your prescription in the slot indicated. Click the Add button. Line up your prescription so all of it is seen, then tap the camera icon. Tap OK and wait for prescription to upload. Remove your prescription. Repeat steps 1 through to 4 to add another prescription or data form. Enter your telephone number and other details. Tap Submit Prescription and take receipt. The Quick Prescript app is also available for your smartphone from the Google Play Store or the App Store. Simply download and install the app and register your personal information. Here's how the app works. Select the Quick Prescript app on your phone. Tap the plus icon. Select the appropriate answer for the pop-up question. Take a picture of your prescription. Select Use Profile Details if it is your prescription, or complete the contact information if you're submitting for someone else. Select Health Card or Cards. Pickup location. pick up time, and which of the items you want from the prescription. Select Done to submit prescription. Brought to you by the National Health Fund, your partner for healthy living.
Support we need to overcome life's many challenges, especially when it comes to our
Thank you very much, gentlemen. We're back with you. And it gives me great pleasure to welcome Dr. Michael Abrams. He's a humorist, poet, social commentator, obstetrician and gynecologist. I think you're in for good times, and his topic is entitled Best Medicine. So may I just ask Dr. Michael Abrams to join us. Thank you.
Right now, me I go give you a thing called feel up your breast. When bitty titty, to pick up cancer in them would be such a pity. How to prevent that cancer, we're not really sure. And although we are try hard, we still can't find no cure. So early detection is your best protection, and self-examination. So look good upon them appearance and investigate them texture, and appreciate your own breast tissue architecture. In other words, make sure say you utilize your hands to get yourself acquainted with your mammary glands. So the minute there's a change and you notice something strange, you can pay your doctor a visit so them can find out what is in it. And if cancer is the diagnosis, you could have a good prognosis if you catch it before it starts to spread. Cancer no means say you have it dead. So touch yourself, feel up your breast, put your hand upon your chest. Self-examination is the key if you want to catch cancer early. Yeah. Right now, me I go give you a thing called feel up your breast.
Thank you, Dr. Michael Abrams. Very interesting. Best awareness. Okay, best medicine and best awareness. And we just finished breast month, right? Okay. It gives me pleasure to bring on our next moderator, Dr. Lori Ann Fisher, consultant nephrologist and intensivist at the University Hospital of the West Indies. And her segment is entitled The Way Forward, Life with Lupus During and After COVID. Dr. Lori Ann Fisher, we welcome you.
Hi, everyone. Good afternoon. My name is Dr. Fisher, Lori Ann Fisher, actually. I am a nephrologist at the university. Unfortunately, you know, in about 2/3 of patients with lupus, kidney involvement occurs, and it's very common. I'm pleased to be part of the Lupus Foundation Symposium this year. And it's actually my pleasure to introduce one of my mentees, Dr. Joel Wright. He is an excellent physician. He's a graduate from our own University of the West Indies, Mona. He currently works as a general practitioner at El Shaddai Medical Center. I had the pleasure of working with him in the capacity of a medical resident, and he's very intelligent, very interested in lupus, and very, you know, about to embark on his training in internal medicine and thereafter in rheumatology, which is for a specialty of internal medicine that specifically deals with lupus and conditions like lupus. And so without further ado, I'm going to introduce Dr. Joel Wright. On a side, he's also a saxophonist, so that's excellent as well. But I'm going to introduce him, and he is going to talk about his research in lupus and patient perspectives. So thank you. I'm going to try at the end of this, of his talk, and also kind of Dr. Stacey Davis, who is going to kind of introduce our panelists with questions. I'm going to feel free for all of you guys to ask questions as well at the end of our presentation. Thank you.
Good day, thank you for having me. I would just like to go through a little internal survey that was done by the Lupus Foundation of Jamaica, COVID-19 pandemic on lupus patients at the Lupus Foundation of Jamaica. So just a little background on what the Lupus Foundation, or the LFJ, is about. It's a non-profit, volunteer-run, member-based organization that's dedicated to improve the lives and outcomes of persons affected by lupus. And this is done in multiple ways. For example, we offer education and information to patients with lupus themselves, as well as their families, the disease more, as well as allowing the family and the public to really understand this, really understand the disease a little better. They get education and information through monthly newsletters and updates about lupus and what's new in treatment, or just what's new in the world of lupus, really. In addition, healthcare providers are also educated and information provided in the forums such as this medical symposiums. The LFJ plays a fundamental part in advocacy for patients through contacts with government organizations or policymakers, for example, the National Health Fund, and pretty much advocating, for example, most recently, subsidization of medications for persons who have lupus. The Lupus Foundation also provides support through medical assistance on a case-by-case basis, support group meetings, and free professional counseling for persons who are members of the foundation. On March 11, 2020, the World Health Organization declared COVID-19 a pandemic, and this has caused a ripple effect in many areas of life. And it's not just directly related to viral infection at all. But we've seen where, there are studies that have shown that there have been changes in the average work hours or even job loss associated with the pandemic. Also, for example, we've noticed that there have been high rates of symptoms and depression. Symptoms of depression and stress in a transcontinental study involving the US, Turkey, China, etc., other countries. Lupus is a multi-systemic autoimmune disease with potentially life-threatening complications affecting mostly women in the peak of their productive lives. So in addition to physical ailments or physical disease that persons with lupus have to deal with, the debilitating symptoms, particularly during flares, they have other things that they have to contend with, that side effects of medications. The medications themselves, they cost, and sometimes treatment can be very expensive. Persons with lupus may sometimes find themselves being in and out of school or work because of disease flares or for whatever other reason, because it's chronic fatigue or pain, or just unable to make it to school or work. And the family can be affected in multiple ways, including financially. And they may have experienced relational difficulties because of the sporadic and unpredictable sometimes nature of the disease, and frustrations may arise because of that. So this pretty much forms the basis of our pursuit, or the reason that we wanted to do this survey in the first place, because we think that persons with lupus already have been affected. Well, baseline, they already have a stressful situation going on, and so we want to determine and objectify really to what extent have they been affected economically, psychosocially, and as it relates to healthcare access. So our objective is really, again, we're really to experience and to perceive the needs of patients with lupus at the Lupus Foundation of Jamaica as it relates to economic and job status, psychosocial well-being, and really just substratified into their mental health, social impact, education, and help seeking. We also wanted to assess their experience and perceived needs as it related to healthcare access and behaviors, as well as risk behavior. So the method was that we had sent out surveys to 129 members of the Lupus Foundation of Jamaica through a customer relationship management software through emailing. There were 5 members who did not have emails, and these were contacted by calling to complete the survey by hard copy, as well as an online survey tool, that Survey Legend. And really the aim of doing all of this is so that we could increase the power of the study and to decrease the sampling bias. We want to determine that we want to ensure that what we truly measure is truly representative of what's going on in the Lupus Foundation. So standardized questions were extracted and modified based on those domains previously listed from the Phoenix toolkit. And these were, a questionnaire was really formulated by compiling these questions. Reminders were sent periodically to encourage compliance, and the testing period spanned October 1 to 14, and then it was extended to October 18 to increase the response rate. So let me just get into the results quickly. It had a response rate of 12%, and all respondents were female. The age distribution, as you can see, the majority of persons were over the age of 35, about 62% of them being between the ages of 45 and 64. 87% of persons who responded to this survey actually had lupus, and 13% of them were a bit unsure of the diagnosis. They weren't sure whether they might have had lupus or not. And in addition, we wanted to look at the comorbidities, and we can see that 9 of them had unspecified other comorbidity, and as you can see listed the other comorbidities that were present among the respondents: hypertension, obesity, asthma, and 1 person with kidney failure. Regarding economic impact, we discovered that 72 or 73% of persons did experience some amount of work-related change, and we had stratified that to see the various ways in which their work situation had changed. As you can see, most persons actually had to switch to working from home or working remotely. 1 person was actually laid off. For some, work became harder, or some had to change work days or hours, and for a few work became risky and dangerous. As relates also to the economic impact, we had asked how their income had changed since the COVID-19 pandemic, and we had found that half of respondents actually had a decrease in their income since the COVID-19 pandemic. Also, half of respondents also had an increase in household spending since the pandemic. We wanted to assess patients' mental health. 56% of persons experienced some degree of low mood over the period. 83% or 82% of persons had experienced some amount of feeling stressed during this time, and 62% had some difficulty concentrating. All respondents actually reported some degree of anhedonia or difficulty enjoying things that they previously once enjoyed. Regarding social interaction, fortunately, all patients actually left home less often than they did prior to the pandemic. 69% of respondents had experienced physical separation from social support. That's isolation from close friends or family. And 81% of persons experienced leisure activity restriction. Regarding healthcare access and behavior, we found that most persons actually didn't experience any inability to access medical care for a serious condition. So 82% of persons were able to access medical care for serious conditions if needed. However, half of persons actually canceled a visit or avoided care completely because they couldn't travel to the facility, either because of fear of visiting the facility or because they had difficulty traveling. 94% of persons have used telemedicine, and 14 of the 16 respondents were actually interested in using telemedicine. We wanted to also assess the risk behaviors. So we asked, to what extent have you followed the following protocols as stipulated by the government? And we see that 3/4 of persons always observed hand washing and face mask wearing, and half of persons always observing physical distancing, with the remaining sometimes or often observing these protocols. And finally, we wanted to assess respondents' access to technological devices. All respondents had access to a smartphone, and most had access to a computer or desktop. And you can see the rest that are listed out there. So let me just get into the discussion quickly. I first and foremost want to address the response rate of 12%. It's really low, and I think we have a few ideas as to why that could be so. Firstly, not all members of the Lupus Foundation actually have lupus. As it was mentioned earlier, it is a volunteer-based organization. So it consists of members of the public, even physicians themselves. So not all members have lupus. A few persons actually misunderstood the target population, thinking that it was really only for persons who had who were infected with COVID in the past. In addition, the testing period was during Lupus Awareness Month, and it was quite a busy month. There were lots of activities, so I would presume that there was a lot that was vying for persons' attention. Although emails were sent out as reminders, phone calls may have been helpful, and a longer period of exposure could have also alleviated the poor response rate. Additionally, the gender discrepancy or female preponderance that is noted, all respondents were females, and this is really pretty much in keeping with the way in which lupus grossly disproportionately affects women. So economically, from the results, we can see that financially there was an evident strain on patients during this pandemic. While there was a decrease in income, with one person even being laid off, there was a concurrent increase in household spending, and this obviously has implications on the patient's ability to meet monthly needs, taking care of the family, purchasing medications or doctor's visits, etc. So we really wanted to know this information so that we could suggest ways in which the Lupus Foundation can help. And we think that we can empower persons with information regarding certain social services and directing them to social services, so that within the constraints of their disease process, they may be able to find some economic viability that is substantial and that is safe and that is sustainable without through directing them through organizations such as the PATH program or the Poor Relief Fund, which also do provide temporary relief for persons who are experiencing acute stressors or any catastrophic event. So, I mean, even the COVID pandemic would really qualify as an adverse event that may be impacting persons who may need some temporary relief. Psychosocially, it has been suggested that stress may be a trigger for increased disease activity for some persons with lupus. And we've noticed in our study that there are comparable levels of stress that were reported, 82%, and in the studies mentioned previously, 81% in the general population, as well as a slightly higher reported symptom of depression, particularly low mood, anhedonia, difficulty concentrating. And these were found among the members of the Lupus Foundation. There are a couple of things that may contribute to these mood symptoms and stress, right? So there stay-at-home orders and physical distancing that leads to separation from close friends or family and the inability to be engaged in the regular enjoyable activities. These may contribute to the mood symptoms and the stress that persons are feeling, but in addition, they may compound with the symptoms that persons are having. So ways in which the Lupus Foundation may alleviate or assist with these, and some of these ways are ways in which the foundation is already working in. You know, we can have targeted support group meetings and particularly aimed at improving stress management and coping mechanisms, and just even identifying symptoms of depression and anxiety, right? The Lupus Foundation also, I mean, opens its doors for individual counseling currently, and would even want to just further reinforce or just reiterate that this is what the organization is for, and just to pretty much give appropriate referrals where needed for persons experiencing psychosocial distress. We set out to determine members' needs and knowledge and use of the support systems available to them that may be related, that they may use in this pandemic, but unfortunately we couldn't really ascertain this information because of misinterpretation of the question that was asked. Perhaps clearer questions could have been asked with examples as opposed to leaving the question open-ended. Also, the knowledge of the way in which the pandemic has affected persons' education and training was important to us, but this domain wasn't applicable to the majority or to really to the majority of patients, and it's made possibly owed to the fact that most respondents were over the age of 35. As it relates to healthcare, generally healthcare was seen as accessible by respondents. However, half of persons still avoided care or canceled appointments because of fear of contracting COVID-19 or because of transport difficulties, and this has many implications, right? So even though patients should be educated that there has been no increased risk of COVID-related complications found in lupus patients to date, right? Many persons did have high risk comorbidities, and that may have accounted for their avoidance of care or canceling appointments. And we know that with avoidance of care, that patients run the risk of relapsing disease. What can the LFJ do about that? So we can foster improved adherence through optimal use of healthcare, for example, with the use of telemedicine, as opposed to having patients self-discontinue their care out of fear. And this is further reinforced by the American College of Rheumatology through their 2020 guidelines on just pretty much management of patients, of rheumatic patients during this pandemic. So that's one of the ways in which we can assist them by optimally using healthcare through telemedicine. As we have seen, most persons were actually interested in telemedicine and actually had access to a smart device. So we can encourage physicians really to make the best use of telemedicine to patients so that they can still receive holistic care without having any relapse of their disease. We also sought to determine the pattern of risk-taking behaviors among members. When commendably, we found that the majority of persons were compliant with protocols stipulated by the government to reduce the risk of transmission of COVID-19. But the question still remains, are these findings representative, or do they fully embody or characterize what the typical patient with lupus in Jamaica is experiencing during this pandemic? And we think that these findings may not necessarily be externally valid, truly characterizing those of the entire lupus population in Jamaica, because persons who are part of a support group differ in many different ways from persons who are not involved in a support group. Firstly, we think that persons in a support group such as this may have different responses because they may be a little more educated about their disease. They have social support, a community of other persons with lupus. They may have a little more education or understanding or awareness as it relates to social services or help that they may find. Also, persons who are part of this foundation may be a little more invested or interested or passionate about their health or lupus as a complete entity, and maybe more invested in letting the public know more about this or helping others who have lupus know a little more, right? The age may also play a part. The average age of onset of lupus is about 22, and we know that in our study, most people are over the age of 35. Level of education may be a little bit different for those in the Foundation of Jamaica. So we wanted to, or we will, or we're currently planning rather, a study really that is in conjunction with the other partners to pretty much capture the experience of the broader lupus population. We really want to determine how it is that they're being affected by this pandemic, and we'll be targeting patients in a convenient place where they seek health care through the clinics and through private rheumatology offices, patients of all age groups and through various methods of collection. And we're aiming to send out invitations by as early as early 2021, about January, February. These are my references. Thank you for listening. Good day.
All right. Good day, everyone. Thank you, Joel Wright, for your presentation. It was very informative. I think we do need to have more qualitative studies on patient perspectives on kind of lupus, not only in the context of COVID-19, but patient perspectives on their own disease activity. Do you think that, I have a specific question to Joel, Dr. Wright. Do you think that if you had 16 people in your sample, do you think that if you had a broader sample of patients, you would have different outcomes, or you think it would be the same?
I think based on the number of persons that the invitation was sent out to, 135, and only having a response rate of 12%, I do think that there might have been a difference in, possibly could be and I suppose it also depends on the question that was asked, but I do think that there may be some issues as it even relates to internal validity. Like, does it really apply to all of the Lupus Foundation, since it was just such a short or a small amount or a small number of respondents? So I'm not certain if we would have the same response.
And my second question to you was, did you note any difference in the amount of flares that patients had? Because you said, there was a part of the questionnaire that mentioned, people were afraid to go to see their physicians. Did you notice any increase in the amount of flares that patients had as a, not necessarily as a consequence, but, or any difference?
Okay, right. So we didn't really ask specifically or qualitatively about lupus flares specifically, but we did ask persons if they did have any increase in medical conditions that would cause them to have to seek medical care, and the majority of persons said no, they didn't have any increase in any medical conditions during the pandemic. But no, we didn't ask specifically about lupus flares, but I think that's important to find out also, and I think I would like to know about that more in the study to be done next year.
All right, so just in the interest of time, because we're a little bit behind now, I think there's one more question about ethical approval, but I think we are going to wait for those questions until the end, right, and then we'll get back to you, because there's, I guess, 2 more questions in the chat. I think at this point in time, we're gonna go ahead and do the short film, which is Patient Perspective series. So the voices of lupus warriors in the COVID pandemic. And thank you, Joel, for your time and your excellent presentation.
In what ways have you or your loved one been most affected by the COVID pandemic, or how are things different for you than before?
Oh, well, for me, because of COVID, I'm not able to go up and down and to take part in a lot of things that I would normally take part in, and that makes me unhappy. Yeah.
We just work with whatever the government say. We just work with it. So it don't affect us. It stop us from go to school, only stop us from going to church. Okay. Yeah. But that's it.
Well, there's nothing we can do, because it's not just us alone. So we just have to, just as best as possible, do what we are asked to do, and to make sure that we stay safe and take care of ourselves. So that's
If we were able to get together experts in a room to provide solutions and tools to address your most pressing issues related to life during COVID-19, as a lupus patient, what would you most want them to address or share about?
Okay, if we can find some special kind of mask to wear, because when you have to keep on the mask, for me, I have a problem when I wear the mask too long, and when I finally take it off, sometimes my throat hurts me. And I know that is not that I have COVID or anything, because after a while it goes away. So if I can get copies, mask with something I can breathe a little better, then probably that will work for me. And with the medication, sometimes we don't get all the medication that we need. I don't really feel scared traveling back.
Have the medication that is most necessary available, because most times when you go they are short or they don't have any for days or weeks.
Hello, everyone. Thank you again. At this point in time, I'm going to invite Dr. Stacey Davis. She is a rheumatologist at the University of the West Indies, Mona campus. She's one of our distinguished members of the Lupus Foundation, a colleague and an associate lecturer at the University Hospital. She's going to introduce our panelists for a few kind of comments and questions and answers. So without further ado, and also in the interest of time, because we're a bit late now. So thank you very much, everyone.
Afternoon, everyone. Thank you, Dr. Fisher, for the welcome. As per usual, the afternoon session of the symposium is usually primarily dedicated to the practical needs of the lupus patients. And this year, it certainly wasn't difficult to figure out what the most topical issue was going to be: living with lupus during and after COVID. And I think most of us have probably heard of the term pandemic, but I'm not sure how many of us really thought about how much it would affect our day-to-day lives and our existence. And so we're all navigating this extraordinary world event together and facing a numerous number of challenges, questions, and needs. And one of the challenges that is facing our lupus patients is simply just accessing medical care, as institutions and providers change procedures and protocols to protect both the patient as well as staff. And then in terms of the patient, they have a fear of traveling, one, and two, a fear of coming to a medical facility where there may also be other persons who have COVID and getting exposed to the virus. And this, of course, is leading to underutilization of healthcare. So in essence, what this has told us is that we have to rely more on technology at this time. And historically, Jamaica has held more, retained the traditional way of providing healthcare, and that is the face-to-face interaction between the patient and the physician. And culturally, a lot of our patients actually look forward to the social interaction with the physician, and not only just the physician, but even staff, other staff members with whom they have developed relationships over the year. Accessing healthcare, however, in COVID means that we have to practice social distancing. And part of that means that we have to minimize unnecessary face-to-face encounters. And both the American and European rheumatology associations have put out guidelines in keeping with this. So when we refer to telemedicine, what we're actually speaking about is accessing healthcare through a virtual platform. And it can be as basic as just a telephone consult, or it can be a video call. And then in the most sophisticated of settings, it can actually use software that allows for auscultation, listening to the heart, or examination of the eyes. In essence, though, when you use telemedicine in the appropriate context, the appropriate patient, it is a service that can give you a similar benefit. It's also important for us to remind our lupus patients that they shouldn't view the distance of not having a face-to-face visit as just a loss to connect, because in fact, telemedicine allows for co-sharing or co-management. In an ideal consult, the patient would actually provide to their physician their weight, their most recent blood pressure, and therefore provide valuable information through the monitoring of their vitals, therefore feeling some control over their own health as well. There are also patients, some of my lupus patients have said, you always want me to do blood tests before I come in. Is it safe for me to be going out to these labs, or safe to go and do an X-ray? The truth is that, especially in a patient who is having active lupus and who has the need to have their medications changed and adjusted, the labs form a very important part of the evaluation. Just remember though that certain laboratories such as biomedical will actually come out to your home, albeit at a cost, but that is one way to reduce exposure. If you tend to go to the same lab all the time and you've developed somewhat of a relationship, it may be useful to just ask the lab tech or the phlebotomist if there's a time that you should come when there's low traffic. Same thing applies for having to do imaging studies such as X-rays. And maybe what you want to do too is go early in the morning before there's a lot of contact exposure, a lot of people coming in and possible contamination. And also where possible, I think some of these places that didn't routinely use appointments are doing so. So you could try and look at it from that point of view. Of course, if we're talking about accessing healthcare, we have to talk about the drugs. And during this pandemic, we need to look at both the availability of the medications our lupus patients use, as well as the safety of staying on these drugs. I'm going to defer availability to Mrs. Julianne Gemot, who will be speaking shortly, but I just want to reiterate, because our morning speakers actually touched on quite a bit of what I had to say, but we know that a lupus patient who is well controlled will have a better fighting chance against COVID. And so there's more benefit to staying on your medications than stopping them. The only time that you should hold them is if you get active symptoms of an infection, such as a fever, shortness of breath, cough. You would hold them temporarily, go and get checked out, and then determine when would be the appropriate time to restart. And it's interesting to note, even if you feel you have an infection, if your prednisone dose is less than 10 milligrams, you're on NSAIDs such as ibuprofen, Voltaren, meloxicam, and you're on your hydroxychloroquine. These drugs can actually be stayed on regardless of an infection. However, apart from the direct implications on your health, the far-reaching consequences of COVID-19 are yet to be fully understood by any of us. For now, we have felt and can only surmise further the impact on our individual and collective safety, our financial protection, scholarly and employee engagement, work conditions, and job security. The enormity of the adjustment needed with the rapid evolution of our understanding, the change in guidance from experts, and the accompanying toll on resources, basically needs for us to have support in so many levels. With all of this comes a challenge of social distancing and the loss of traditional and valued connections, COVID-19 fatigue, and associated depression. We all need to just stay tuned, as this is a rapidly evolving situation which requires continued adjustment. It's a good thing that lupus patients have always been warriors, and I'm sure they're up to this fight as well. Today, we will, through the upcoming panel discussion, address many of the aforementioned matters and other concerns raised by our lupus patients. So please join us now for what should be a supportive and useful discussion with our local experts. So at this time, I'm going to go ahead and introduce and welcome our esteemed panelists. I'm going to start with Dr. Jacqueline Duncan. She's a consultant in internal medicine and occupational medicine. She attained her bachelor's in medicine and bachelor's in surgery in 1994 from the University of the West Indies. She went on to do an internal medicine residency at Columbia University in New York. She also holds a master's of public health and is certified in occupational medicine, having completed an occupational medicine residency from Duke University Medical Center in North Carolina. Dr. Duncan is currently a senior lecturer at the Department of Community Health and Psychiatry at the University of the West Indies, and she will talk to us about safety in the workplace. Our next panelist is our guest of ours. This is Ms. Tanya Ralph. She holds a Bachelor's of Arts as well as a Bachelor's of Laws degree, both from the University of the West Indies. Additionally, she holds a certificate in legal education from the Norman Manley Law School and certificates of mediation, family life education, essentials of occupational health and safety, as well as public speaking and presentation skills. Ms. Ralph's substantive work life has seen her progress to being legal officer at the Ministry of Labor and Social Security and at the Industrial Disputes Tribunal, as well as co-chair of the disciplinary committee at a particular government department. Ms. Ralph is a member of a number of community outreach committees, and she has a passion for health and wellness. And she was sharing us the legal implications of COVID, particularly in the workplace. Ms. Damily Beeson, she's not a stranger to most of us who are involved in the foundation. She's been helping the foundation for many years, and she's a medical social worker at the University Hospital of the West Indies, where she has been serving for over 10 years. She attended the Northern Caribbean University, where she completed a bachelor's degree in counseling with emphasis on social work in 2007, and she recently completed a course in crisis, very timely, trauma and grief counseling. She'll be speaking to us on COVID, surviving on a budget and accessing government resources. Mrs. Marsha Norman, another guest who we'd like to welcome, holds a master's degree in human resource development from the University of the West Indies. She's a human resource manager at the Courtyard by Marriott in Kingston, Jamaica, as well as offers human resources consultancy services. She's also an author and motivational speaker. Mrs. Norman will guide on approaches to retooling during the period of job and financial instability associated with the pandemic. We have the honor of having Professor Roger Gibson, who heads the Department of Psychiatry at the University Hospital of the West Indies, and who also practices privately in Kingston and in Mandeville. His main interest is in depression and related disorders. He has also had specialized training in consultation liaison psychiatry, which tackles the issues at the interface of physical and mental health. Welcome, Professor. And lastly, but certainly not least, we have Mrs. Julianne Gemott. Though being a highly esteemed pharmacist by profession and currently working out of the Ministry of Health, today Mrs. Gemott has joined us in the capacity of being someone challenged with lupus. Her life pivoted in late June of 2009 when she noted some minor changes to her health. By August of that year, when her symptoms were not getting better, she sought medical attention. She was diagnosed with systemic lupus and with lupus nephritis. She went into renal failure, was hospitalized, and underwent emergency hemodialysis. Although some persons would have been depressed at this diagnosis, she drew strength from her family, friends, faith, and an unassuming 8-year-old patient who was also undergoing dialysis. She was not afraid of her diagnosis. Diagnosed with lupus for over 10 years, she often shares through her social media inspirational quotes for her fellow patients and caregivers, as well as information to raise awareness about the invisible diseases such as lupus and myasthenia gravis. She's a daughter, sister, aunt, wife, but most importantly, a lupus warrior. Ladies and gentlemen, Mrs. Julianne Gemott. So at this time, I'm going to ask Dr. Duncan to go ahead and share with us her prepared statements looking at the basic principles of workplace safety. Dr. Duncan?
Okay, good afternoon, everyone. I have 5 minutes, so I'll just jump in. So why is the work important in this time of COVID? Well, we know that there have been clusters of COVID-19 reported in several workplaces, from call centers in Jamaica to processing plants in the US, cruise ships. We know the risk is particularly high among healthcare workers. WHO recently said 1 in 7 COVID-19 cases are actually healthcare workers. But there's also data coming out from several countries that actually there's an increased risk of infection and death among work occupations that have close and frequent contact with the public. So this includes your security guards, your taxi drivers, your bus drivers, your postal workers, and even store clerks. So the role of work in COVID-19 is very important. The ILO, as a result, International Labour Organization, has identified 4 pillars of action to lessen the impact of COVID-19 at work. So some of the actions of governments that you see have to do with these 4 pillars. So fiscal policy, social protection, but I'll focus on pillar 3, which is how do we protect workers in the workplace. So we can think of COVID-19 as an occupational hazard, something dangerous to your health at work, really. And an approach that occupational health professionals use is that you have the hierarchy of controls. And we like to jump to PPE, personal protective equipment. That's your gloves, your mask, your goggles, your hazmat suit. But really, in the workplace, we consider that there are actually 4 levels of controls that are more effective and very important that we don't neglect. So the first 2 we can't apply to COVID-19, elimination of the hazard. We can't remove COVID. It's here and it's here to stay, maybe forever, I don't know. But we do know we can certainly use what we call engineering controls, where we use mechanisms to remove the hazard, or administrative controls. And this really involves innovation, looking at how you work. How does your organization operate on a day-to-day basis, and what can you change to make work safe? And then in conjunction with that, we use our personal protective equipment, your mask, etc. So your engineering controls are things like looking at ventilation. And there are studies that show that just being in a closed, cramped quarter with air conditioning and recirculating air increases your risk of COVID transmission. So opening the doors, the windows. In hospitals, we use negative pressure ventilation, use of physical barriers. So your face visors, we see the glass barriers going up in reception areas. And then there are also other mechanisms you can use, like your air handling units having high efficiency air filters, which are used on airplanes. And then your administrative controls, as I mentioned, we have to look at the workplace. How can we make it safer? So simple things, of course, we know working from home, and I say feasible because not everyone can work from home. If you're sick, stay home. Transmission is higher if you come with a fever or a cough, etc. Staggering hours, so there's less crowding in the workplace or even at the bus stop. Education, of course, how to properly protect yourself. Teleservices we heard about, so the aim is to reduce face-to-face contact. If you have to have face-to-face contact, you try and keep it to less than 15 minutes. And good hand-eye hygiene. And of course, we keep hearing about masks, gloves, etc. But there are studies that show even among healthcare workers, when COVID-19 infection occur, it's from not handling your personal protective equipment properly. So, you know, basic things like make sure you're handling your mask from the strings behind your ears, not touching the front of the mask. If you have to touch your mask, to wash your hands before and after use, not touching your eyes, etc. So it's not just about providing personal protective equipment, but it's also how you use it, how you dispose of it, how you rest it in between use may lead to contamination. And finally, I'll say a word about reasonable accommodation. So these are things that you have to look at in the workplace, the hierarchy of controls. But of course, not everything we recommend to the employer that they will be able to accommodate the worker for. Because as I mentioned, the employer might not be able to allow everybody to work from home. So reasonable accommodation basically says that whatever accommodations or modifications that we ask the employer to do, it doesn't impose or a disproportionate or undue burden on the employer. So basically, it won't cause them to become bankrupt, or they can't afford to do it, or it's just too large a task. So really, for safety at work in the time of COVID, we have to be innovative. We have to consider the employee, what is the risk to the employee, and also look at how we can reduce the hazard, whether it's using engineering controls, administrative controls, and of course, we have to use our personal protective equipment wisely. Thank you.
Thank you, Dr. Duncan. I just wanted to ask you, you brought up the concept of reasonable accommodation. But the question is, I'm a lupus patient. I may have other comorbidities that are even making me more high risk, some hypertension, cardiovascular disease. And my employer doesn't see the need to go beyond, say, masks or sanitizer. Who decides reasonable accommodation? Is it the policy of the company? What grounds do I have to go further?
Yeah, so it's really emphasizing that it's sometimes a negotiation between the patient's doctor, the patient, HR, the company. So it's not a one size that fits all, and I'm sure the legal person may become involved. The Ministry of Labor may come involved as well. So, it starts though with the patient, the doctor, the HR team, looking at the work situation, looking at the risk, and deciding what accommodations need to be done or what are recommended, and the company deciding if they can really absorb these sort of recommendations, and sometimes you have to escalate it. Unfortunately, we don't have our Occupational Safety and Health Act that has been promulgated, but we're still governed by the laws of the International Labour Organization. And depending on the company, if it's an international company, if it's a US company, they have to observe the OSHA laws, etc., the company where their parent company resides.
Okay. Another concern I've heard is patient privacy. So I have had patients who would like a letter to document that they do have chronic underlying illnesses. They may not want the employer to know that it is lupus because, there still is some lack of understanding of certain conditions generally. And so you would write, they have a chronic underlying systemic illness, and you would get back that you need a specific diagnosis. Or I've had a patient who then they required a formal medical report. Is there a line that the patient can draw, or once you're employed and in such a situation as a pandemic, the employer has the right to know the specifics of your medical history?
Yeah, so there's always a line that the patient draws. It's the patient's information. So usually when we do fitness for duty, that's basically what you do as a physician. You basically need to know what the patient's job is, and you make a recommendation whether they're medically fit for the job. It doesn't include saying that, the person has HIV or lupus or whatever. So if the company requires such detailed information, certainly the patient must consent to revealing. It's not a routine thing that HR requests information and you give it to them. The patient must consent to that kind of detailed information.
Okay. And then you pointed out that probably the most essential part of the hierarchy of preventing spread is going to be to stay at home. Even if a patient does not work directly with the public, are you saying that on a whole, if your job allows you to perform your tasks and provide deliverables, you should then look towards staying at home?
Well, I wouldn't say it is the, remember I said that you have to look at each patient individually. So what is their risk? How high risk? We heard earlier that the risk based on studies aren't necessarily as high as we thought it was for all lupus patients, right? It depends on comorbidities, etc. So each case, you have to look at the employee, you have to look at the type of job they do, you will have to look at whether the job can be modified, because the truth is, as I said, not every company can allow every employee to stay at home. So it might end up without them having income. And we've had situations like that. So we have to look at how can we make the job safer. So sometimes it might be task shifting. So instead of face-to-face interaction with a customer, they're reassigned tasks. But of course, the safest thing for anybody is to stay at home. But in reality, we know that that is not feasible for everybody. So you have to look at what are the mechanisms we can put in place to reduce the hazard, whether it is engineering control or some other administrative control. So doing task shifting, or it may be, putting up mechanical barriers or having special staggered hours for the employee. So it's a very dynamic situation that really involves creative thinking and negotiation as well.
Okay, thank you. So we're going to move along to the next panelist, Ms. Tanya Ralph, who will now give us more the legal aspects. What are the provisions in the laws in Jamaica for a situation like this, a pandemic, and how both employer and employee need to respond. Ms. Ralph.
Thank you, Dr. Davis. Can you see my screen?
Yes, we can.
Very well. All right, so the time is limited and I will move as quickly as I can. I was asked to present on obligations, rights, and expectations at the workplace during COVID-19. How I've decided to approach it is to look at the expectations, and then as I look at the expectations, you will see coming out of it what the statutory obligations are as well as rights. And by statutory obligations, what I mean is simply this: those duties that arise by virtue of legislation, and legislation is law that is created by the parliament of our country. So let's move along. There are 5 major points that I want us to look at: layoffs and redundancies, variation of the contract of employment, contract of service, same thing, a safe system of work and healthy work environment, continued compliance with statutory obligations and continued rights under the labor laws of Jamaica. Now, the expectation on both the side of the employer and the employee is that with this virus that has entered our lives, it has impacted all aspects of our lives. What is going to happen? What is likely to happen in the workplace? So there's layoff, and I'm sure the term is not foreign to many of us. The layoff is really an option that the employer may choose to exercise as his business goes through difficult times. So as we may be able to appreciate, COVID has come, and the financial impact it has had, sorry, has been quite significant on businesses, and many businesses are finding it very difficult to make as much profit as they used to carry out the different roles that they used to, and that is impacting their bottom line, which is profit. Really and truly, layoff is an attempt by the employer to stave off redundancy. Now, there is an argument that layoff is a right of the employer. I don't agree. When you look at the legislation, it comes across as an option, but the employee has a right to say to his employer, if he has been laid off, and there's a maximum period within the law of 120 days, so the employer can lay off an employee up to 120 days. If after the 120 days, the employer doesn't call back the employee and say, okay, things have improved and we're going to take you back, then that employee now has the right to send a notice, a written notice to the employer saying that he wishes to be regarded as dismissed on the basis or by reason of redundancy. And that notice should state the effective date that they want that, that situation to start, and it's usually between 14 to 60 days after the date of notice. Now, what really when we talk about, so we've looked at layoff and we're looking at the redundancy aspect. Redundancy, what is it? How does it come about? And really a redundancy situation will come about where the employer is either moving the actual place of his business, and there's no clause within the contract of employment to say, okay, if something happens, we can, move our business place from this point to that point to X point. Or it may arise where the employer has ceased or intends to cease the business. So simply put, the business has to be shut down. Or it may arise where the employer needs to reduce the labor force numbers in order to keep the business afloat. Or where the employee has suffered a personal injury which has been caused by an accident that arises out of the course of his employment, or that employee has developed a disease. And the list of diseases that would qualify is listed in the employment. The ETRPA means the Employment Termination and Redundancy Payments Act. Now, to be eligible for redundancy to be made redundant, and it's the position that is made redundant, not the person, the employee must have been working with the employer for at least 2 years continuous service. To get redundancy payment, one of the things that the employee must do, and as I say, I may be saying employee, but as I say, I'm speaking as well to the employer. The employer needs to know what it is that he would have to do as well, and what the employee would be required to do. So the employee must ensure that he sends a written claim for the payment within 6 months after his dismissal, or 6 months after the employer has agreed the amount that is to be paid. If it's outside of that 6 months, it is likely that if it goes to the court, it will be statute barred. In other words, your right would have been done away with. The formula for calculating redundancy: 2 weeks pay for every year worked of the first 10 years. After 10 years, 3 weeks pay for every year worked. The Ministry of Labor and Social Security, the PCEB means Pay and Conditions of Employment branch, is always there to provide guidance for you if you have any questions in relation to these issues. And I want to underscore that in an employment relationship, communication and dialogue are crucial. My friend before me made the point that negotiation, in several things that she said, she raised or pointed out negotiation. Negotiation is crucial. Dialogue is crucial. Never underestimate the power of it and the usefulness of it. Next point, what can we expect? Variation of the contract of employment. So with COVID, we're aware that the disaster risk management orders have been promulgated by our government, and one such is the curfew orders. Because of that, many businesses have had to shift their start time and end time. And also, they may change the actual days that you have worked, because again, with business, a downturn in business, they may not need an employee for every day of the week. So those are things that may give rise to a variation of the contract. What do I mean by variation? Simply put, a change in your contract of employment. Of course, you can appreciate or may be able to appreciate that with a variation, it may also lead to reduced pay. There may be new duties or additional duties. So for example, with the need to check people's temperature at the door before they come in and sanitize, and other additional duties in order to ensure that the staff is protected and that nobody is at risk. Another instance that may arise or lead to variation in the contract is new working arrangements that may have to be considered by the business, by the employer. WFH means work from home, and WR means working remotely. There's a difference. Working from home means you're working from the confines of your home. Working remotely means that you can work from some other place, some other location outside of the main office environment. Third point, a safe system of work and health environment. I won't spend much time on that because my friend before me dealt with it. All businesses really and truly all employers should already have in place a policy or a system that will allow for a safe system or place of work for employees and for themselves as well. Presently, it is a common law duty, but as my friend said, there's the occupational safety and health legislation, not yet out of the pipelines, but being worked on assiduously, and that will place greater duties on employers and employee because there's a balance there. So if the business doesn't have a safety policy in place, they need to, or if they have one, let me start there, they need to review it and incorporate the COVID protocols, which we all know by now, wearing your mask, physical distancing, washing your hands, sanitizing, etc. If there's none in place, one needs to be framed and implemented and to ensure that the COVID protocols are included. Point 4, continued compliance with statutory obligations. So yes, COVID has come, COVID has changed our lives, there's a new normal, but that does not mean that it has changed the law in respect to what duties an employer has to an employee and what duties the employee has to an employer. Because remember, it's a relationship, you both work together. Under a contract of employment, contract of service, same difference, the employer has certain obligations to meet. So for example, in respect to maternity leave, notice periods, in respect of termination, proper procedure in respect to how you terminate, vacation leave, sick leave, minimum wage. Those things have not disappeared because COVID has entered our lives. And the final point, a continuation of our rights as per the labor laws of Jamaica. So for example, right to proper notice, right to due process, and there are others. I will leave it there for now, Dr. Davis.
All right, thank you, Ms. Ralph. We're gonna move on to Ms. Beeson, who will talk to us about living on a budget and accessing financial aid during this period. Ms. Beeson, are you there? I think I saw you earlier.
Yes, hello.
Hi.
I'm here. Good afternoon, everyone. Thanks, Dr. Davis, for the invite. So I'm to speak on surviving the pandemic and community resources that we can access during this time. So in terms of surviving the pandemic, you have, say, a reduced budget, or your income has been reduced and you have the same bills to pay. How do you go about surviving on that? Well, our first recommendation would be that you have to look on your expenses, household expenses, and prioritize, see which ones are necessary for family survival. So you have to cut back on expenses, and if it's possible for you to join with other family members, either by way of them assisting you, or if you can join with a household, if possible, to share household expenses, rent, bill, light bill, water bill, then that would be great to do. Some persons also think about finding other skills to utilize to make another means of income. So if you have other skills, you have to try to be creative at this time, you know. So that's basically for survival. And some community resources that we can access during this pandemic. For government resources, it was touched on PATH, the PATH program. They have some grants called Rehabilitation Assistance Grant. This is a grant that focuses on income generating projects for individuals and families. So if you want to go into harvesting crops, farming, chicken rearing, the PATH office can assist you with that. For the compassionate assistance grant for persons who do have hospital bills and you're not able to pay all the bills, then the PATH office could assist you with this type of grant. You don't have any insurance coverage, you need assistance with medication or funeral expenses. This grant assists with that. Their contact is 967-0889 or 967-0890 for the PATH office in Kingston. They are located island-wide. So in each parish, you can visit your PATH office. The other community resources, Poor Relief Office, they assist with persons who are destitute, you're unemployed, you really don't have any family support. They do visit your home, come and do an assessment, and they assist you with funding every other month. It might not be a lot, but it helps, at this time if you don't have anybody at all. The government provides that type of assistance or intervention. They also assist with housing. Conditions apply. So you can contact Poor Relief Office for financial assistance. Also with medical expenses, if you are registered poor, you won't have to pay hospital fees, or you can come to your clinic free of cost once you're registered poor. Their number is 922-6937. For NIS National Insurance Scheme also assists persons, pensioners who have been, contributing for their entire work time and they have lost income as a result of injury on the job, as a result of incapacity, or they're retired, or they are dead. Family members can access NIS benefits if your family member was a contributor of NIS. They also provide funeral grants as well. And there, so I mentioned PATH, Poor Relief, NIS, and Jamaica Council for persons with disabilities. Some persons may ask if lupus is a disability. It would not be considered a disability, but if the condition has affected your ability or loss of function over a period of time, you're not able to work as a result of your medical condition, then the Jamaica Council could assist with that. Presently, though, they are only working with persons who are already registered with the disability. But you can still contact them and see how best they can help. Their number is 968-8373. We also refer patients at the University Hospital to the Ministry of Health and Wellness for compassionate funds if you need assistance with surgery procedures. At this time, it's a bit challenging because of COVID. The focus is now more on funding patients who have those conditions, but we still try to assist persons as well as refer them to their member of parliament in their parish or area for financial assistance. I hope that was helpful. I don't know if you have any questions. Is that?
Yes, thank you, Ms. Beeson. Definitely helpful. We're going to ask Mrs. Norman now to contribute, because in addition to looking for aid, we also have to look at how we can reinvent ourselves and provide new sources of income. So we're going to hand over to Ms. Marsha Norman.
Good day, everyone. Today I want to speak to you under the topic Reset, Refocus, and Retool. Due to the pandemic, some persons have lost their jobs, or if they haven't lost their jobs, they are in fact working reduced incomes. So we want to see how well we can enhance our income or establish another source of generating an income to take care of ourselves and our families. I want to start by saying that everyone has a talent, everyone has a gift or a calling. In terms of enhancing our income, I want to point to three options. We could do a physical business, an online business, or online remote jobs. In terms of physical business, private tutoring is a big one. Persons want to keep safe, and they're trying to balance the need to be safe and the need to provide person-to-person contact in terms of learning. During, I think, April, May, I heard about a teacher, so schools were still not open. I heard about a teacher, she reached out to the parents of kids in her class, and she told them, meet me at the park, Emancipation Park. I have arranged transportation services for the kids. It was fairly big. She observed all the COVID protocols, but she had private tutoring, and she charged $1,000 per day per child. So you see, it became quite lucrative. I think it's the same now. So there's opportunity in private tutoring. Some persons weren't really teaching, but they have experience in math or chemistry. Persons are willing to pay for their children to have private tutoring, face-to-face contact. Perhaps an overlooked area that is earning big bucks for some persons is cooking and delivery services. Whether you can deliver or persons come to your home and pick up, that's another lucrative area. Under the current system, persons are observing curfew orders, but they still have to eat, but they're not going out to restaurants. So cooking has taken on greater significance. I heard of a case, this gentleman, he was living in New York, and he decided to come home, and his job, his full-time job now, is preparing porridge. He extended the kitchen at a relative's house, and he's preparing porridge, delivering porridge at persons' workplaces. And if he's telling the truth, he's making a profit upwards of $200,000 per week. So cooking and delivering is a major area where we can enhance our income, but we actually have to be good at it. Delivery services, concierge services, some persons are not doing online banking, so they're still standing up in lines to various government entities. So even before the pandemic, concierge and delivery services, persons were doing that for extra income. Farming, some persons don't want to go to the market, so if you have resources, if you don't mind being a middleman, or if you have a farm yourself and a reliable motor vehicle and you want to deliver to neighbors or a nearby area, that's always good. Arts might be a more long-term investment, but if you can paint, you draw, you do pottery, you write, still put the effort in, still put the passion in, and share it on social media, generate buzz about what you're doing, and you can actually benefit in the long run. In terms of online businesses, some persons really don't want to go back in the physical space during the pandemic. online business remains a viable option. One of the main earners is selling information products. What does this mean? If you're an expert in your field, then this can be monetized. It can be something complex or simple. Can you draw? Can you play the guitar? Can you sew? Do you do well at gardening? So if you can do it, most likely you can actually teach it, and you can teach it on an online basis. So you can create your YouTube channel, a website, you can conduct webinars, write ebooks, create blogs, and advertise on Facebook. So selling information products online is a big money earner. You might be saying, I don't want to sell information products. You can do affiliate marketing. What does this mean? So you have a strong presence on social media. You can actually sell products for other persons or companies. You can start a blog. You can increase your email listing. Some of the ideas that generate traffic on social media that you could host on your own website or on a blog, areas like health, fitness and weight loss, self-improvement, personal finances, areas like that, you can seek out how best you could engage in affiliate marketing. There's also room for membership websites. If you can produce interesting material, then you can charge a membership fee. Also, the selling of handmade goods is a big money earner. So there's market for things like jewelry, crochet products, paintings, pottery. These things will do well on the internet. So, and you have specific websites where you can actually advertise and make money by selling. And even before the pandemic, some persons usually complain of a hostile workplace. So they perhaps didn't do well in the physical setting, but they see potential in selling handmade goods online. So this is an area worth your time to do some research on and see the best option. You don't want to do a physical business or an online business. You just want a job. There are online or remote jobs that you can benefit from. Also, you have virtual assistant. So not everybody is internet savvy or social media savvy. They are good at what they do, but many times they want a virtual assistant to help them to promote their goods or schedule meetings, things like that. So a virtual assistant makes good money online. A graphic designer, persons may have their books or they may have information for their website, company logo, things like that, but they need a professional to do it. So there is scope for earning if you're a good graphic designer. Course creator, this is like a teacher, but the teacher is online. So you might have a book, or you're an expert in a particular area, you can create a series of lessons, put it on a website, put it in a blog form, and you can actually earn from this. So course creator, have your material ready, and then you can actually teach it, create the courses, subject by subject, area by area, advertise, charge persons a fee to actually access, and then you can earn some substantial amounts from that. Sales can be done online. If you're bilingual, you can translate documents for others. So this is a good area. Persons sometimes have website material or books or items they just want to advertise. They want second eyes, and they want an editor or a proofreader. If you're good in that type of thing, you can earn money also. So what are some of the top sites to go to if you're want a remote job, you have Upwork, Craigslist, Amazon, Freelancer, you have a website called Hire My Mom, many others. What I would advise, just Google it, just go on Google and type in remote jobs or working from home, and you will see a number of websites popping up. Look and see which ones are the best, but I found these: Upwork, Amazon, Freelancer. Those are some good ones. I want to end by encouraging you not to give up. You will succeed. Don't you ever give up. You will succeed. What I encourage others to do is to write down whatever vision they have, whatever skill they have. Now is the time to do a personal SWOT. Get a journal, get a diary, or a little scrap of paper, and you write your top 3 skills or your top 3 knowledge areas, and then think about strategies that you can do to or implement that will enable you to earn from it. When you have done that, put timelines on it. So we shouldn't be talking about the same thing next year. Put a timeline on it. You say by the end of November, I'm creating my own YouTube channel. I'll be having my own website. So put a timeline on it and then work towards it. Be hopeful, be thankful. Remember, with God, all things are possible. I am expecting you to do well, so go for it. You can do it, and don't worry about failing at any attempt. You can practice what is called failing forward. So make an attempt, learn from it, and try again. There are lots of options out there, whether physical business, online business, or getting a job, a remote job. You can do it. Just start. You have nothing to lose. You are going to be successful as we look towards ending 2020 on a positive note and marching victoriously into 2021. All the best as we seek to enhance our income. Thank you.
Sorry. Thank you, Mrs. Norman. We're going to go straight into Professor Gibson's talk on achieving resilience and maintaining our relationships during this struggle of being in the pandemic. Thank you, Professor.
Hello, good afternoon, everyone. So just let me share screen. Oh, there we go. So a few words on promoting resilience and accessing mental health support during COVID-19. So what is psychological resilience? This refers to overcoming odds, surviving, and therefore moving beyond challenges. Now, resilience has been best studied among children, and research among children shows that resilience is something that is shaped by experiences over time. There are also a number of internal and external factors that contribute to resilience. One important internal factor is personal temperament. So children who have pleasing personalities tend to attract help and support, and this support helps them to overcome challenges. Family bonds and community support, including mentors and role models, also help children to achieve resilience. If we talk about resilience in adults, then here are some factors that are very important. The more socially connected you are, the more likely it is that you will be resilient. Persons who are able to appreciate positives, which perhaps most of us would overlook, tend to be more resilient individuals as well. Persons who have strong goal orientation and a strong sense of purpose are also resilient persons, as are persons who engage in healthy pursuits. So if we were to develop a crash course in resilience, and bear in mind what I said earlier, that resilience is usually something that develops over time. But nevertheless, if we were to engage in a crash course in resilience, and these are some of the factors that we should consider. You should try to draw on positive social resources, including family, friends, and colleagues. Seek help when you need it. Check your temperament and attitude. Is it a positive attitude? If it is, then you're on the right track. Look for and appreciate the positives in any situation in which you find yourself. Work towards your purpose, whatever that purpose may be, and try to have a healthy and balanced lifestyle. So how does all of this apply to COVID-19? Well, I think we're all very aware of the challenges that COVID-19 has presented to us. Some of them are threats to our health and our lives, isolation, diminished independence, financial problems, and clearly being resilient would help us to overcome these challenges. So going back to the crash course that we just developed, the first point was to draw on positive social resources, family, friends, and colleagues. So in the context of the COVID-19 pandemic, this may include things like talking things over with trusted persons, remaining socially connected, including via phone, social media, in person with the necessary safety precautions, seeking help from the social resources that we just mentioned, i.e. family, friends, and so on, but also from mental health services if a deeper kind of assistance is required. In terms of temperament and attitude, be positive, as I said before, be open to helping others, be empathetic, and try to appreciate the positives. And speaking about appreciating the positives, here are a few examples. For many persons in the COVID-19 pandemic, it has afforded them more quality time with family, so that is a positive. It has helped them to find time to work on projects and ideas that perhaps they had abandoned or neglected previously. For all of us, the challenges that we're facing now, we can try to frame them as learning experiences, and therefore that they are experiences that will help us as we move forward. Work towards your purpose. So because of the pandemic, that doesn't mean that we have to abandon whatever our purpose is. Is your purpose to become a better parent, to master a particular skill, and so on? Keep working towards that purpose, because that is going to help you to be resilient and to overcome the challenge that you're facing now. Having a healthy and balanced lifestyle would include things like exercise, relaxation activities, and proper nutrition. So finally, a few words on accessing mental health support. Mental health support services are available in both the public sector and private sector. Many of the entities in these sectors accept both self-referrals and referrals from healthcare professionals. So you can ask your own healthcare professional or any healthcare professional whom you know about how you might be able to access these mental health support services. There are also helplines that are available, and on the slide here we have one of the helplines, which is from the Ministry of Health and Wellness, 888 New Life, which is a helpline dedicated to mental health needs in the COVID-19 pandemic. So those are a few ideas about resilience and accessing support. And I'd be happy to have further discussion with you about these points. Thank you.
Thank you, Professor Gibson. So we're going to close now with our final panelist, Mrs. Julianne Gemot. Mrs. Gemot, go ahead.
Hi, good afternoon, everyone. Accessing healthcare in COVID-19 era can be very stressful for the lupus patient, but they must be encouraged to manage their condition as much as possible and prevent flares. The impact of COVID-19 may be a snowball effect for the lupus patient. Let's look at patient one, who is still working, but may have cutbacks at the workplace resulting in lost income and health insurance, but still needs access to their healthcare professional, laboratory services, and treatments such as medication and dialysis. Patient 2, on the other hand, has lost their job and has no income nor health insurance and depends on family and maybe friends for financial assistance and still needs access. But before proceeding with my presentation, a few assumptions about these patients are made. Both are stable, they own and can operate a smartphone, has family support and access to transportation, and very importantly, are members of the Lupus Foundation of Jamaica. A visit to the private healthcare provider may cost the patient anywhere between 8,000 and 12,000 Jamaican dollars. However, patients are encouraged to keep their scheduled appointments. They need to follow protocols set out by the Ministry of Health and Wellness and the facility by sanitizing, practicing physical distancing, and wearing their masks. Technology, such as computers or mobile devices, can be employed to virtually consult with physicians from time to time. There may be a period where the patient may no longer be able to afford these visits, and that is a reality which must be accepted. And physicians should therefore support the patient's need to attend a public clinic. A public clinic visit costs anywhere between free and 1,200 to 2,400 Jamaican dollars. As in the private setting, patients should keep their appointments and follow protocols. Since the clinic may have many clients, patients are encouraged to arrive at least 1 hour before scheduled appointments for clearance procedures and carry a family member or friend for support. Lab works are essential in the management of lupus patients. Patients should access labs that offer special discounts to Lupus Foundation members. One of the many benefits of membership, patients can visit labs at times when they are less busy and again follow the necessary protocols. Patients are encouraged to use the services of 1 to 2 pharmacies, one of which is the primary. For example, if you normally use a government pharmacy system, have a community pharmacy for backup. If the primary pharmacy is out of stock for your medication, develop relationships with the pharmacist. Sign up for the NHF card or update medical conditions, as the NHF now covers lupus and many associated conditions. Use generics wherever possible, as these offer lower price alternatives. Prescriptions can be faxed and WhatsApped to many pharmacies now to decrease waiting times. However, remember, original prescriptions must be submitted upon collection of medication. Some pharmacies are also offering delivery services. Check with your pharmacy if they are 1 hour or if the possibility can be arranged. Lastly, inquire if your pharmacy offers discounts to Lupus Foundation members, as many do. Thank you.
Okay, thank you, Mrs. Jamat. We're running a little bit behind. I'm not sure, Madam President, are we able to take any questions? I'm not hearing anything, so I guess I'll go ahead. I haven't received any questions. So I'm looking at what are the recommendations re-lupus patients taking a COVID-19 vaccine, if and when it is approved. I'm not sure if this is a panel discussion for that. I think we still need to know more about the vaccine. Because as you know, lupus patients, depends very much whether vaccine is live or killed. There are lots of considerations before patients with autoimmunity and on immunosuppressants can decide whether a vaccine is for them. So that will have to come in the future. Do we have anything related though to any of the questions, any of the presentations from our panelists? I have a question for Professor Gibson. If a patient feels they're doing poorly in terms of not coping with the changes with the pandemic, are there any red flags that they should know about to know, yes, I really need to seek help. I need to get some advice from a mental health specialist?
Great. I had difficulty unmuting my microphone, but yes. So I think an important thing to be aware of would be what are some of the normal responses, and to know if those normal responses are now trending into somewhere different where mental health intervention would be required. So in the COVID pandemic, we can expect anybody to have a fair amount of anxiety because of the whole situation, maybe some fatigue, maybe some low mood that is happening from time to time. But what would send up this red flag that you're talking about is if these symptoms are persistent, so there's really little or no reprieve for these experiences. And two, if it is that what is going on is having a significant impact on the person's ability to function, both socially and occupationally. So is, for example, their work output significantly lower than it had been before? Is it that they're socially withdrawn and not interacting with people on an ongoing, unending kind of basis? So that is what I would say. Know that there are normal responses, but if these are persisting and if they're interfering with their level of functioning, then that would be a red flag to seek help.
Okay. And so in the interest of time, I'm going to thank all of our panelists. We really appreciate the contribution you've given today. And I'm just going to summarize and say, the key points are: be very deliberate in taking care of both your physical and mental health during COVID. Key stressors are fear, financial strain, separation from family, loss of freedom to do regular activities. Make sure you keep your appointments though to guarantee your physical health. Stay on your medications. Remember, in your work life, negotiating and discussing with your employees key to getting the adjustments needed for your workplace instituted. If you have had a loss of income, look at all the possible resources out there to assist. As Ms. Beeson said, think of sharing expenses, look towards PATH, look towards NIS, grants that are available. Think about learning a new skill or using a skill you have before and retooling, learning a new way to meet your obligations. Certainly, if you are not doing well, remember the helpline, 888 New Life through the Ministry of Health that can provide you with support in terms of your psychosocial health. Thank you all. I'm going to hand over back to our chairperson.
Okay. Thank you very much, Dr. Stacey Davis and Dr. Lorian Fisher, and to your panelists, Dr. Jacqueline Duncan, Ms. Tanya Ralph, Mrs. Marcia Norman, Mr. Malik Beeson, Professor Roger Gibson, and Mrs. Julian Gemma. Thank you very much for a really quite interesting segment. And we're closing in just 3 or 4 minutes, but you don't want to miss final musical item coming up shortly by Dr. Joel Wright. You will love it, I think. It only for us to thank all those, the sponsors. May I just thank the sponsors again. National Health Fund, our major sponsor, Dr. Reddy's from our drug partner, IPCA, drug partner, and Boeing Ringer in Engleheim, Wissinco, all the stuff that they produce and distribute, water, cran juice, everything. Imagination, they are graphic designers. The Gleaner Company, they've been with us from 1834. Well, not with the Lupus, but in Jamaica, 1834. Auto Channel, motor car dealers, importers, and of course, our technical team, Esri Ram, right here, Alex and Miguel. We couldn't have done without you guys. We're not that versed on these technical matters. And It's been a pleasure coming on from 8:30 this morning to do the setup. If you look at all these 10 computer screens and everything, it's high tech, really, right, Desiree?
Very much so.
And I don't want to thank those who work behind the scenes, apart from, it's like Sherry DeRosa or Rochelle Thomas, Khadijah Green, and all our web personnel and social media partners. We want to thank you very much. It takes a lot to stream this thing on Zoom, YouTube, and Facebook. Lupus Foundation is fully a voluntary group, started in 1984, as Desiree told you earlier on. Stacy's a past president, and Dr. DeCoola, President Emeritus and the longest serving president. I'm going to turn over now to Dr. Tollery to just give the rest of the vote of thanks.
Thank you, Cedric. I think you've covered most of it. All of our presenters have been thanked, especially our invited guests, Professor Caricchio and Eisenberg.
Is she on? She can use, right? Yeah, okay.
Yes, we can be on together. And of course, our very high level known presenters like Dr. Tanisha McGee, Dr. Raquel Lowe-Jones, and Dr. Joel Wright, who is many of you are meeting, and you'll be hearing a little bit from him as well. We thank our moderators for so skillfully handling the sessions and bringing out all the necessary information. We thank you all for your questions. We're sorry that they all couldn't be addressed at the same time. We'll see how many can be addressed subsequently in the chat, especially on social media. And we want to thank those who've done our special features, like Dr. Jessica Yap, Mr. Kevin Jackson, who did the special video feature, Patient Voices, and also Joel, as you'll be hearing from, the production team at Ezeron, as you've been saying, and our digital web social media teams that did a lot to raise attention. So many volunteers. It's really been a team effort. It's been wonderful. We thank you most of all, our gracious participants coming on early this morning. We see that there were delays, but many of you have stayed on till the end, and you'll be blessed as we close out with this wonderful blessing that you don't want to miss. It's in a musical form. And what better note to end this program, which has been one of hope and one of going towards the future. And so let's listen to Joel Wright, Dr. Joel Wright, as we close out.
Thanks, everyone.
Thanks, everybody. See you next year.
When you walk through the storm, hold your head up high, and don't be afraid of the dark. At the end of the storm, there's a golden sky and the sweet silver song of a lark. Walk on through the wind, walk on through the rain, though your dreams be tossed and blown. Walk on, with hope in your heart, and you'll never walk alone. You'll never walk alone. When you walk through Don't be afraid of the dark. At the end of the storm, there's a golden sky and the sweet silver song of a lark. Walk on through the wind, walk on through the rain, though your dreams be tossed and blown. Walk on, with hope, hope in your heart, and you'll never walk alone. You'll never walk
has one of the highest rates of lupus worldwide, with thousands affected by this serious, lifelong, and in some cases, life-threatening autoimmune disease that often strikes without warning at the peak of their productive lives. Delayed diagnosis or treatment continues to cost lives. Persons affected may also struggle with the debilitating effects of the disease, disrupting their lives, high costs of treatment, and just the challenge of daily life with a condition that may be poorly understood by families, co-workers, or the community at large. On the other hand, with early diagnosis, access to the right treatment, knowledge, and support, persons with lupus are able to achieve optimal health and live fulfilling and productive lives. The Lupus Foundation of Jamaica has been here to make this goal a reality for patients with lupus. We are a volunteer-run, member-based charitable organization in operation since 1984 that is dedicated to improve the lives and outcomes of persons living with lupus through information, support, advocacy, and research. We conduct public awareness campaigns through live and print media, interactive website and social media platforms, and organize medical symposia and public lectures to educate health professionals in the recognition and treatment of lupus. In 2019, we distributed over 3,000 pieces of literature through hospitals, clinics, and outreach events. We made over 400 direct support contacts through our learning center, providing persons and families with information about lupus, help in finding treatment centers, and connection with a support community. We have continued to provide our members with access to discounts, medical insurance, free professional counseling, monthly support group meetings, access to interactive learning sessions with health professionals, WhatsApp support groups, as well as regular newsletters and updates. In 2019, we joined with a vibrant, the Lupus support group, Western JA, extending our reach to patients and families in Western Jamaica. Similar groups are soon to follow in St. Anne and the South. We were able to work with policymakers and government bodies such as the National Health Fund to provide substantial subsidies for costly medications for all lupus patients. We secured and facilitated the donation of key diagnostic equipment to the UE Renal Pathology Unit to boost diagnosis and training for lupus renal disease that will help save lives. With partners like the Sagicor Foundation, we are working to secure equipment that will shortly make critical diagnostic tests accessible to lupus patients to help detect persons at risk for serious complications. The COVID-19 pandemic has posed new challenges for persons with lupus and also for work at the Lupus Foundation of Jamaica. With God's help, we have met these challenges as we witnessed among our board, members, volunteers and friends, an unmatched display of compassion, courage, collaboration and ingenuity, service and support. We have been able to keep our communication channels open through electronic messages and online platforms to maintain our monthly support group meetings and to sustain our warriors' sense of community and connectedness. We continued to offer free professional counseling via online platforms, take support calls, and to use diverse platforms, including social media, to support our members through the COVID crisis. During Lupus Awareness Month this October, in addition to our live and print media campaign, our volunteer team staged an unprecedented social media campaign under the theme Knowledge of Lupus Saves Lives. We launched new programs including Ask the Expert and Your Story Fridays, and increased our reach to over 12,000 persons gaining awareness and knowledge of lupus. We staged our first virtual Laps for Lupus Awareness event to raise funds for our member medical assistance fund, while also lifting spirits and bringing members, families, and old and new friends together in a sense of community in support of our warriors. And now the best of international and local experts have come together with the help of our sponsors to stage our 23rd annual Lupus Symposium in virtual format for the first time, with record participation and streaming across Jamaica, the Caribbean, and the rest of the world. With your help, we can continue this work and do even more to win the fight against lupus.